Welcome, everyone. My name is Ken Loy. I'm the Ifso Apc treasurer, and today is the start of the 2 days program that going to bring all our Asian friends and also even overseas and USA and European people together to enjoy the 2 days conference. As you know, we're supposed to be in Colombo, Sri Lanka, enjoying a bit of coconut and sunshine, but we probably have to do it next year some stage. And we're going to give you talk about food, right? Bariatric is about food. So today is not just an a la carte menu. Today is a degustation menu. So we are starting with our entree today. And 3M has been a company that is actually just newly joining the healthcare, and we are very grateful for them to actually sponsor the symposium. And the theme for this conference today is about bariatric surgery because it's rising in Asia, and we can see a lot of prospect of growth in terms of taking care of diabetic patients and also all our patients that are obese to try to help them to lose weight to achieve resolution of metabolic problem. But on the other hand, I think we want to understand the good, the bad, and the ugly of the bariatric surgery. None of the patients are ever ugly, none of our speakers are ever ugly, but we need to understand about it. And 3M actually acquired KCI, which actually been heavily involved already with a lot of your patients that you may see with a lot of wound issues, if they're obese, diabetic, have major laparotomy. And so this conference is about teaching you guys about after bariatric surgery or before bariatric surgery. If you encounter obese patients, and there are a lot of other issues like hernia, plastic size, if they lose weight, that's the good bit of it. How do you deal with it? And we're very fortunate to have 3 speakers from Asian Pacific regions, and their talks will go back to back. I encourage all of you to send questions during the time. If we cannot answer, we'll endeavor to get back to you. And hopefully we'll achieve the entree side of things. So we have 3 speakers. The first speaker is our Japanese surgeons, Professor Riyad Ogawa, and he's professor of plastic reconstructive surgery in Nippon Medical Hospital in Japan. And very grateful that Kelly's logged in. I think she's supposed to operate. But I'll introduce everyone all in one go because the talk will go back to back, and then there'll be a discussion afterwards. So Professor Riyad Ogawa actually studied abroad in Harvard and Boston and done his research in terms of all the wound management and scar issues regarding of plastic surgery afterwards. And is also editorial board member of a lot of internationals and scientific journal, and has widely published about 40 chapters of books and have 270 papers already. So we will listen to him about his experience. And afterwards, we'll have Professor Kelly Slater, which I know quite well. Yeah, I'm down south in Sydney, and Kelly is in Queensland, Sunshine Coast. The border just been open. So I'll get all my big patients who had hernia problem. They're going to flood you, and you're going to be busy for Christmas, which you are now. Professor Slater is not only doing a lot of hernia surgery, she's actually a transplant surgeon and leading towards a lot of major open surgery. So she's not shy of dealing with all these big patients. And I'm sure we'll be very glad to listen to her experience about how to manage the wound afterwards and what her experience is about. Because I think in Asian Pacific, there are a lot of patients that are even worse problem with diabetes that we have to deal with as well. Last but not least, we had Professor Haejin Lee from Singapore, NUH, and she's also a plastic surgeon that had been trained in King's College and in School of Education in London in 2007. And she come back to serve Singapore in 2016 and form an integral part in Singapore Medical Council as well in terms of her plastic surgery. And she will share with us the interest on facial reconstruction plastic surgery. And I'm sure we'll know about a bit more about how 3M try to manage healthcare. As you know, 3Ms is everywhere. They're in the sticker post, they're in your roll paint and everything else, but healthcare is something that they realize that as a material company, they will endeavor to put more effort in. And I think it's tying to our bariatric surgery afterwards or beforehand. So I will ask my colleague to start the presentation now, and then let's enjoy it, and then we have a discussion afterwards. Thank you.
Okay, so I'd like to start to talk about the NPWT mechanisms of action. I'm Rei Ogawa from Tokyo, Japan, plastic surgeon. So we have to know the first innovation of wound healing was started in UK. It was Dr. Winter. He said moist environment is very important for accelerating wound healing. According to this very important study, the wound dressing materials has been developed a lot in the world, and now we can use sophisticated wound dressings for wound healing. Actually, the wound healing is smooth and the epithelialization will be completed if we can keep moist on the wound. Actually, after that, second innovation of wound healing was in US. It was Wake Forest University. The negative pressure wound therapy was developed by a plastic surgeon in Wake Forest University. Actually, they wanted to keep moist on the wound, but they wanted to drainage wound fluid. So the negative pressure wound therapy was developed. And actually in 1995, the first device was on the market by KCI. And many plastic surgeons started to use NPWT, but everyone has surprised its results. Just moisture control cannot achieve such good results. The effectiveness of NPWT was tremendous. So we have started, what is the main mechanisms? Maybe another mechanisms exist in addition to moist wound therapy and suction of exudate. So an important mechanism was found in Boston. It was wound healing and tissue engineering laboratory in Brigham and Women's Hospital in Harvard Medical School. I was joined in this laboratory, and Dr. Ogel, the boss of the laboratory, he said there are mechanisms is macro deformation and micro deformation. Macro deformation means when we start vacuum, tissue deformation can be occurred, and tissue distortion occurred. And at that time, micro deformation occurs. Micro deformation means tissue is changed and under suction, and cell is stretched, and many gene expression will be changed. So when we start vacuum, tissue is distorted, and the structure is changed, and the cells sense mechanical force, and the cell membrane, the many molecules exist, and the many molecules on the cell membrane sense mechanical force, and this signal go into the nuclei, and the gene expression will be changed. Actually, when we start negative pressure, the shear stress and the hydrostatic pressure will arise on the wound surface. So this is in vitro NPWT study. We made this device and we compare normal culture and the negative pressure culture. Fibroblast is cultured, and the NPWT treated groups, number of cells increased a lot, and also cell shape was changed dramatically. And also wound healing related gene expression was clearly changed. Increased TGF-beta1 basic FGF, collagen, gene expression is accelerated by negative pressure. So actually we can conclude influence on cells of negative pressure is cell proliferation increase, morphological change increase, and gene expression change increased. This is in vivo NPWT study using diabetic mouse. The wound healing of diabetic mice decreased. But the NPWT, actually, we compared occlusive dressing therapy, foam, and continuous mechanical force and cyclical mechanical force. But NPWT didn't accelerate wound closure percentage. But important things is NPWT increased thickness of granulation tissues. It is clearly different compared to occlusive dressing therapy and foam only. Also, we analyzed blood vessel structure. The blood vessel was analyzed using electron microscopy. So this is no control, no treated groups, but after treatment of NPWT, the healthy and pliable blood vessels we could find. Actually, NPWT reduced hypoxia we could find. So in the results of in vivo study, we can conclude granulation tissue increased, angiogenesis increased, neural fibers increased, and the hypoxia decreased. So actually, this is the study of mechanobiology. Mechanobiology is a study area to think how do organs, tissue cells sense mechanical force. Actually, in recent years, many cellular mechanosensors can be found in the world. And there are many molecules on the cell membrane, and including integrin or cell adhesion molecules, and also cytoskeleton and other molecules can be considered as a cellular mechanosensor. They can sense mechanical force. Actually, when we stretch cells, cytoskeleton is also stretched, and cells sense mechanical force via cell adhesion molecules, and in the results, gene expression will be changed. This is a mechanosignaling pathway. This is a mechanical force change gene expressions. So actually, not only acceleration of wound healing, mechanical force can improvement of surgical techniques, and mechanobiology is very important for analysis of pathogenic mechanisms, and also very effective for aesthetic and anti-aging medicine. So we can redefine the word mechanotherapy as a medicine to orchestrate physical environment of organ, tissue, cells, and molecules. So please keep your mind the word mechanotherapy. So I have organized mechanobiology and mechanotherapy laboratory in Nippon Medical School, and I'm studying the effectiveness of mechanical force on tissues, cells, organs. So NPWT is one of mechanotherapy devices. This is motion therapy and suction of X-state and mechanobiology. So after this discovery, concept was completely changed from how should we drainage X-state to how should we provide appropriate mechanical force for accelerating wound healing. So actually, this is a case treated by cyclical mechanical force using 125 mHg. So debridement was performed, and the granulation tissue increase after starting mechanical force NPWT. Granulation tissue increase, blood vessels increase, and 3 weeks after treatment, the nearly wound is closed, and 6 weeks after treatment, the completely wound is closed. So please remember, negative pressure wound therapy is a powerful treatment for wound healing, and this can be used for treatment of abdominal. Open abdomen wound. The mechanism is the same. They keep moist on the abdomen, and also many cells on the abdomen sense mechanical force and start to secrete collagen, and many cells can sense mechanical force and increase wound healing. So I believe understanding of mechanisms can optimize treatment methods. So please remember, NPWT is a mechanotherapy device and can accelerate wound healing and also very cost effective. So thank you very much. This is the NPWT mechanisms of action.
Thank you for asking me to speak about the management of the open abdomen. These are my disclosures. The open abdomen is probably one of the biggest general surgical challenges that we can face. And there's not a lot of literature about the open abdomen, but I am drawing on from my quite extensive experience in managing this condition. I like to think of it in two types of patients. There's the acute open abdomen, typically caused by pancreatitis, trauma, bowel ischemia, or bowel perforation. And this is an illustration of terrible necrotizing pancreatitis, illustrated here with necrotic material in the abdomen. And this patient will need multiple laparotomies and reopening several times. Then there's the patient with bowel ischemia that you may have to have a relook laparotomy, and the traumatic patient with fecal soiling from penetrating injury. Then there's the second type of open abdomen, which is the chronic loss of domain, or the patient with an enteroatmospheric fistula and rectus muscles widely separated. This will again behave as someone who will be very difficult to close. Several things are common to these patients. If you leave an abdomen open, you're committing a patient to a lengthy stay in hospital. They'll be very debilitated. They are at high risk of forming enteroatmospheric fistulas, and they will develop incisional hernia with a loss of domain. These patients always have a higher chance of morbidity for multiple reasons, primarily sepsis, pulmonary embolus, and pneumonia. The principles of managing an open abdomen come in two steps. The first operation, it's all about getting the situation under control, or the damage control laparotomy. You then have to think about how you're going to fix the problem and recognize that an abdomen, once left open, won't be able to be re-entered within about a week, as the adhesive mat will form around the bowels and you won't be able to move them along. It's most important to recognize that you have to have a plan to close the patient from that very first laparotomy. The options for leaving an open abdomen are several. The first one, and has been traditional but not very good, in that you can use a thing called a Bogota bag or absorbable mesh and sequentially close them over a number of days. There's now proprietary products on the market, such as the Adthera vac therapy, to leave the patient temporarily open, and this is the first choice when you're faced with this situation. There are several proprietary patches available to sequentially close the abdomen, which I'll discuss. There's also tension sutures, and then finally an Abra device. So the Bogota bag, I would not recommend, but if that's all you have, you open a piece of IV fluid bag, sew it to the edge of the abdominal wall musculature, and this contains the bowels temporarily. It's very messy, and you would only use it if you had nothing else available. Similarly, tension sutures damage the abdominal wall, lead to incisional hernias, and problems with high risk of herniation and infection. Sequential closure is a labor-intensive procedure that involves sewing mesh to the edge of the rectus sheath and taking the patient backwards and forwards to the OR to slowly bring their abdomen together. Mesh directly placed on the bowel increases the risk of enteroatmospheric fistulas, and again, usually results in wide defect incisional hernias. The Adthera device from 3M is an excellent item to temporarily leave a patient open. Its advantages are that it has a protective layer that covers the bowel, decreasing the risk of early fistulation, and is relatively easy to apply. Most hospitals have this on their shelf, and this would be what you would use in the first instance that a patient is left open. The advantages are that it's excellent for fluid management. It is quite easy to nurse in the intensive care, and it is very gentle on the bowel. After a day or two of being open, however, you need to move to the second step of the principles of managing an open abdomen. And this is to preserve the tissue, especially the rectus sheath and the skin, to prevent the lateral retraction of the muscles and prevent evisceration of the intestinal block. So this CT illustrates what happens if you leave a patient open for a prolonged period of time, and you'll see the rectus muscles laterally retracted and the visceral block has come forward, and you've left a patient now with an abdomen with bowel on view, and the only solution in the past has been to skin graft this, putting the patient at high risk for enteroatmospheric fistula. So I would suggest that you never let a patient's abdominal wall get into this situation where you can see the bowel on view. This patient has been in the hospital already for 6 months. This patient's abdomen needs to be closed, and I'm going to show you how you can do it. So you need to plan very early to bring these patients back together, like the patient on the left here, who has only been left open a matter of a couple of weeks. Their rectus has not had the opportunity to go sideways and retract laterally, and they are relatively easy to close. As opposed to this patient here, who has been left open after a pancreatectomy and has significant problems with loss of domain and will require a major procedure to close. So the Abra device is another very useful item that we have available in our armamentarium, and I use this very frequently in association with a grey foam back device. This is very similar to tension sutures, but is much kinder to the rectus muscles. It prevents evisceration of the bowel, fistula formation, and lateral retraction of the abdominal wall. I found it useful both in the acute setting and the chronic setting for sequential closure of the abdomen. So in the acute setting, it's very easy to put on all types of wounds, both transverse and vertical, and it can also be applied to patients with stomas, as shown in this picture here. It's also very useful in the chronic setting, such as this patient I've shown before, in order to bring their abdomen together when their bowels have been eviscerated, and it negates the need for multiple trips back to the operating theatre. After 14 days of sequential tightening in the intensive care, this lady's abdomen was closed, and she had just one final trip back to the operating theatre to close the midline fascia. As I've explained, this Abra will work on most wounds, and it is available widely in Australia at present. So this video illustrates how the Abra device is placed. The patient is marked circumferentially around the wound at 3 centimetre intervals and 5 centimetres away from the wound edge. Elastomers are fed from one side of the abdomen to the other, evenly spaced at the 3 centimetre intervals. A silicone sheet is placed over the bowel in order to protect it, and this silicone sheet is permeable, and the fluid will run away and out of the wound into the back. As these elastomers are placed, artery forceps are temporarily put on to stop them pulling through. You can see it's far away from the rectus muscle edge, and this is relatively atraumatic to the midline, and will allow the patient to be closed in the future. A pipe is placed under elastomers to further take any pressure off the bowel. This device allows easy reaccess to the abdomen if for any reason a relaparotomy is required. Buttons are then placed to spread the tension evenly across the wound, and the elastomers are tightened to bring the edges of the rectus muscle together. You can see here the patient will be sequentially tightened by my assistant and I, and the rectus muscles will come nicely together. A grey foam vac is then placed in the defect, and the patient is returned to intensive care. This device also allows us to take the grey foam out at any time and inspect the wound. without having to return the patient back to the operating theatre. When the patient is stable, they will return to the operating theatre and definitively closed. And this will be the first time that the edge of the rectus muscle is sutured. So it's not that frequent that this device needs to be used, but it is a valuable tool if you ever need to leave a patient's abdomen open. Okay. So other interesting things you can do with these VACs and the elastomers is to primarily close the patient's abdominal wound without allowing them to heal from secondary intention. I use a Prevena plug after a few days of being open, allowing the infection to pass. I use elastomers just on the skin to hold the edges together without suture closure. Then I place a Prevena vac on top in order to close the wound without it spreading and granulating by secondary intention. This gives a much needed result and allows any infected material to escape. This is a patient who's had the Abra on and then the wound closed using the Prevena vac, and you can see 6 months later he's had an excellent result. Thank you for your attention.
Thank you for having me at this conference. I'm very honored. I'm Han Jing, a plastic surgeon in Singapore, and I'm here to talk about the use of incisional negative pressure wound therapy, Prevena therapy from KCI, in plastic surgery, sharing my experience in body contouring surgery following bariatric surgery. This is the disclaimer. Prevena therapy, as can be seen here, is used on closed, clean surgical incisions. So this is the index patient that I'll be talking about later on. Prior to using Prevena therapy, I've been using the homemade incisional VAC therapy using the standard VAC therapy that we have. The purpose for using this is because these patients generally have a huge defect or very high tensions across the wound. And after closure, the use of this closed incision management would help to oppose the wounds together better, reduce the tension, and I will discuss more. So the index case is a 40-year-old lady who is morbidly obese, had undergone bariatric surgery, and because of this, she had lost all over 20 kgs of weight. So she presented with excessive penises and deflated ptotic breasts, as can be seen here in her preoperative pictures. This lady would like to have her breast reduced as well as the abdominal excessive tissue removed. Because of this, there are opposing tensions that we have to consider. When we reduce the breast, the tension faces upwards, and when we reduce the abdomen all round as a circumferential lower body lift, there will be tensions downwards as well as anteriorly and posteriorly. So surgical measures to reduce tension includes judicious resection of the penis, limited central dissection of the anterior abdomen, tranexamic acid spray, quilting stitches, tension-free closure, as well as Prevena therapy, post-operative garments, and specific post-operative positioning. These are pictures of the intraoperative resected specimen and the placement of Prevena intraoperatively before moving on to breast reduction surgery. A total of 2.4 kg of abdominal skin and fat was removed in this case. We inserted 4 drains, 2 in the anterior abdominal cavity and 2 in the back. 1 week following surgery, as can be seen on these pictures, Prevena was placed circumferentially around the wound. 4 drains are present at 1 week post-op, and during this 1 week, there were minimal discharge collected in the drain bottles. So when the Prevena was removed at 1 week, we also removed 2 of the back drains, as well as 1 drain anteriorly, leaving 1 abdominal drain. Pictures here shows her at 2 weeks post-op. You can see that most of the wounds have been well healed, and she has one drain remaining, which was removed on post-op day 18. A picture of the quality of her scar at 2 weeks shows that it has healed beautifully. Some literature review. Closed incision management started getting in vogue since 2010. Prior to that, there were only a handful of articles available, but now there are over 200 articles across various specialties. The first journal article that I would like to show is this one done in 2013, comparing incisional negative pressure wound therapy versus conventional gauze dressing in 56 patients who had undergone abdominal wall reconstruction for large ventral hernia. As can be seen here, there was statistically significant improvement in wound complication rate as well as skin dehiscence rate in patients who were treated with incisional negative pressure wound therapy. Of course, there are also improvement in skin and fat necrosis, seroma rates, hernia recurrence rate, and infection rate. Another literature here, closed incision management was used in 8 pigs. 4 wounds were created over the abdomen, each measuring 8 by 8 centimeters. Of the 4 wounds, 2 were managed with closed incision management. These wounds were left for 4 days. Following that, the pigs were euthanized. These wounds were excised and weighed. It showed that there was 63% less hematoma and seroma in the wounds that were managed with closed incision management. Further on, during this study, they had placed nanospheres within the wound cavity as a means to detect lymphatic drainage. On skin biopsy, it showed 38% reduction in the amount of nanospheres present and also higher percentage of nanospheres in the draining lymph nodes. These showed that during closed incision management, it increased lymphatic drainage and thus reduced dead space. This other article tried to find out what size of closed incision management best reduce tension, and they used 3 separate sizes: 3 centimeters, 6 centimeters width, and 9 centimeters width. And it was found that at 3 centimeter width, it was best to offload tension across the incision site. And Pravina used 3 centimeter width. So some other journal articles shows that Pravina improved angiogenesis by increasing in the presence of vascularized endothelial growth factors. The presence of these increased neovascularization, increased tissue perfusion, oxygenation, and thus improve wound healing and scar quality. Another literature showed that with Pravina application, there's increase in appositional forces despite irregardless of using sutures or staples. And studying the microvectorized forces showed that with closed incision management, it decreased and aligned these microforces and thus relieved lateral tension across the wound edges. The 2D studies showed that the lateral tension had a reduction of 50% of forces, thus showing that closed incision management would reduce dehiscence as well as improve scar quality. Finally, a meta-analysis done in 2019 finally included 30 studies, of which 11 were randomized control trials, 7 prospective and 12 retrospective studies across multidisciplinary specialties. They concluded that closed incisional negative pressure wound therapy was statistically significant in reducing the incidence of surgical site infection, and the odds ratio in the forest plot for the randomized control trial, as well as the retrospective and prospective studies shown here, favors the use of closed incisional negative wound therapy. Another international consensus done in 2017 with a panel of 12 specialists concluded that the use of closed incision negative pressure wound therapy should be used for patients at high risk of developing surgical occurrences or during a procedure that would have highly morbid consequences if surgical site infection occurred. They algorize this into patient-related factors, as well as incision or operation type related risk factors, as can be shown here in this graph, and recommended the use of closed incision negative pressure wound therapy when there are high risk in each categories. So these are the general incision related factors, as well as the subspecialty related operations. So as can be seen, the use of Prevena would have immediate, intermediate, and long-term effects. So the benefits of Prevena is that it is lightweight, it is portable, the patients do not report any pain or discomfort, there's reduced in the need of frequent dressing change initially, reduces anxiety of the patient because the wound is well supported and they do not feel pain, eliminates dead space, reduce tension, minimize motion at the suture edges, provides a sterile environment, thus reducing surgical site infection, reduce wound dehiscence and complications. This is how Prevena is designed, with an interface fabric foam that is soft and comfortable, the granule foam and drape. The effect of the appositional forces not only affects the skin, it also affects the subcutaneous fat, as well as the deeper muscular layers. These are some of the products that are available by Prevena. There is the peel and place, as well as the customizable size. This is my final slide showing the available Prevena products. Peel and place comes in 3 different sizes, 13 centimeters, 20 centimeters, and 35 centimeters. And the customizable is up to 90 centimeters with very small portable suction machines. I'm open to any questions. Thank you so much for having me.
Great. Looks like we had all the speakers speak about the action and mechanisms of how to manage wound, and hopefully our Asian Pacific colleague can learn from all of you, because a lot of the bariatric surgery, as you know, are done laparoscopically. So hopefully try to avoid patients staying in hospital longer and going home earlier with small wound. And when they lose weight, they will all come to Dr. Lee for plastic surgery. So that's the circle of care. But I guess going forward, we've been affected by COVID, and certainly economy-wise and hospital-wise, we are really affected by it. And the goal of this is to actually improve patients' health and get them earlier home. And a lot of this device that now you can use in terms of vacuum suction device and wound device are all part of it to discharge patient early. And as you know, surgical site infection is one of the biggest costs to our healthcare in United States, and the risk factor we all know is obesity and diabetes, which bariatric surgery are aimed to treat. So I think it's kind of a good complementary for us. I just want to know if there's any question, please send it to the panel. And we have one question so far to Professor Slater. I apologize on behalf of Professor Slater. She actually emailed me and saying that she have to get off to operate on a Friday afternoon. So I guess somebody will have to work. And so the question was asking about the Apera device. Would that increase the abdominal compartment syndrome? I myself has used this device a couple of times in certain situations and pancreatitis patient as well. And once you detect if there's chances of compartment syndrome, you can actually go and adjust and loosen the little rubber band so that you can reduce the pressure for it. So it's adjustable. And I guess it's depending on how you measure your compartment syndrome in terms of IDC, balloon pressures, etc. So I'm very interested in Dr. Lee's view in terms of the suction device. And I think, are you using it mostly on all open wound, or pretty much all your patients that with big wound, you use the Prevena device? Are you on mute?
sorry about it.
That's okay.
So I mainly use it on management, for closed wounds, for big opposing tensions. Yeah. So for bariatric surgery particularly.
Yeah, I would suspect that Azims make the patient skinny and then can send it to you to to get them beautiful. So now I'm very grateful, and I think, as you know, 3M is quite new in terms of healthcare. They acquire ACI, so now they actually have a lot of device in terms of respiratory wise. I've been involved with them regarding of the their normal pressures, ventilations, and also the respiratory device. And the idea is to have patients recover well. So as we all know, surgery wise, everything is a combination effort of all our surgeons and anesthetists and theater staff and everything. So I think they are positioned well to try to help us or help our patients in Asian Pacific regions. So I'm going to check if there's any other questions. If not, then I think we will close the symposium. We have a little break, as we know, between meals and entrees and different degustation menu. We had a bit of a chit chat and wine. You guys can go and start a little bit of food, and please come back at 8 o'clock, where we're going to start going through our history of APC, and then we're going to see 2 memorial lectures of our greatest bariatric surgeon that we know in Asian Pacific and in Ifso Main Center. And thank you, Professor Lee, and I want to thank the other 2 speakers, and Professor Ogawa also had other commitment as well. So if you have any other questions, feel free to email, talk to your rep if you want to understand about how to use the device, because they are sometimes a little bit tricky for the first 1 or 2 times, but once you get used to it, and I think you're going to like it and you're going to use it more. So so I thank you for 3M for sponsoring the symposium, and we'll kick off on our main surgery soon. So main talk soon. Thank you.
Thank you.
Whoa, you look great. Kazu?
Yeah, it's still red, right?
This is the Australian hat,
That's right. It's my favorite hat.
the cougar hat. Very good. Harry, you're going green as well, Spider-Man?
Wow, Harry, again you agree.
It's like a chameleon.
I hope you guys enjoyed. It was a bit of a talk that is a little bit off bariatric, but I think it's
It's nice. And hearing something apart from bariatric is always good. I don't know whether we have this dressing in Hong Kong at this moment.
you should have. I think KCI VEC dressing is very common.
Kazu, we are live.
That's okay. That's good. We are alive. Yeah.
Yeah.
10 more minutes and we'll get started.
Yeah, waiting for that time.
You can start now.
Huh? Really?
There I am. Let's come back. Hi, Cece.
Yeah, I am as well. Yes.
Well, my camera keeps going off.
Okay, if we're going to start formally, then I'll switch off.
No,
Listen
look
to
at that. I'm green. No good.
Tiger bomb.
Hi, everybody.
Hi,
This
Jerome.
lovely outfit.
Kazu, you look nice on the hat.
Yeah, looking good. Yeah, this is my favorite Australian hat.
He's part of Australia now. Next time, Manuel, you come to Australia, we give you one.
Kazu, I think everyone's online, so I think the message is to get started.
Yeah, we can start. So please start. Okay, good. Great. Thank you for joining Ifso Apc Virtual Congress this year. So we have two lectures, two sessions at the first time. History and the future of Ifso and Ifso Apc, and then we have promising technology, East and West. And before starting the session, I have to introduce all the speakers of two sessions. But first of all, I would like to appreciate Dr. Ken Loy for being a moderator of the previous satellite symposium. Maybe you may be wondering why I'm wearing this hat. This is my favorite Australian hat to show my respect to two great speakers of the first session. The first session is a history and the future, so that the first lecture is so-called Kawamura lecture. The Professor Harry Friedenberg will be the speaker. And the second, the lecture is a Skopinau lecture, and Professor Lilian Ko is a speaker. And may I introduce two of them? And Professor Harry Friedenberg is the founding president of Ifso Apc, and he found the APC with Dr. Kawamura and Dr. Lee and Dr. Chobe. And he knows everything about the bariatric surgery from the beginning. And of course, he was the president of Ifso, Peak Ifso. And the second speaker is Professor Lilian Ko. Many of you know that she is the current president of Ifso, and also the past president of the Ifso Apc. Then we're going to move to the second session. We have to get out from Australia. And the second session is promising technology, East and West. The first speaker is Dr. Nathan Zundel, and Dr. Zundel is a clinical professor of the Florida International University. Also, he is the past president of Ifso and the president of IFSES. The second speaker is Simon Wong. He's the president of Asian Pacific Metabolic and Bariatric Surgery Society, and also the president of the Hong Kong Society of Metabolic and Bariatric Surgery. And the third speaker of the second session is Professor Matthew Crow, and he is the director of surgical endoscopy in the Digestive Disease and Surgery Institute at Cleveland Clinic. And the fourth speaker of the second session is Professor Manuel Garboneto. Of course, many of you know that he is a leader of the bariatric endoscopy worldwide. When we talk about bariatric endoscopy, everybody talks about him. The last, not the least, is Dr. Jérôme Dargent from France, and he is a past president of the French Society of obesity surgery, and also the past president of the Ifso European chapter. And he was the chairman of the Ifso New Technology Committees. And he knows everything about the new technology. And of course, we have the poll and discussion after the second session. And if you guys have some questions, you can use the question tab and then ask us. So please enjoy 2 sessions. And let me start from my welcome address. Thank you so much. Enjoy the Congress. Ladies and gentlemen, welcome to our Ifso Apc Virtual Congress 2020. So this is the president of Ifso Apc, Kazunori Kasama. So before talking about this conference, I'd like to ask you to give me a few seconds. So Professor Scopinaro is a legendary surgeon and the father of all bariatric surgeons worldwide. He passed away, so that I would like ask you to offer a silent prayer for him for a while. Please pray for him. Thank you very much. So I would like to talk about Ifso Apc meeting this year. So Ifso Apc meeting 2020 was planned to be held in Sri Lanka today and tomorrow. But it was postponed because of COVID-19, so that we have a virtual meeting. And I had a plan to hold this virtual meeting. I'd like to ask a leading surgeon of this society to form scientific organizing committee to make a program. And they suggested me to hold some memorial lecture for 2 great guys in our society. You can see this picture. This is Professor Scopinaro and Professor Kawamura. So we have 2 memorial lectures. Name of Kawamura lecture, and Professor Friedenberg will talk about the history of Ifso and Ifso Apc. And then the current president of Ifso, Professor Lilian Ko, will talk about the present, the future of Ifso and Ifso Apc as a Scopinaro lecture. Of course, the COVID-19 is the biggest event in this year, so that we have to know how to survive this pandemic. And our speaker has the huge knowledge about that, so that they will talk about COVID-19 and bariatric metabolic surgery. Also, we have to think of future. We have a session of the promising technologies East and West, inviting the world-renowned faculty from all over the world. And also, I need to focus on the bariatric endoscopy in Asia, and the revision and the weight regain is a big issue to us. And East meets West session, because our chapter is a little bit different from other chapter, because we have many Asians here. And also, we have integrated health session regarding nutritional complication and also surgical complication. And I know that many of you would like to see other guys' complications, not your own, but it's a very interesting one, so that we have a compilation of the video complication session. So we have a many interesting session in this Congress. And I would like to appreciate the sponsor of our Congress. The platinum sponsor is Ethicon, and the gold sponsors are Medtronic and 3M, and the silver sponsor is the Fujifilm, and also the Lead Surgical and the Civita Medical are our sponsors. And I would like to appreciate three beautiful ladies, Manuela and Stephanie from Ifso, and Stefania from MCM to organize this conference. So I always say that the metabolic surgery by APC surgeons for APC patients with APC evidence is a quite important issue to our society. So that from now on, for 2 days, for 2 days, please enjoy our scientific feast of our society. Thank you, and let's start it.
Hi, everybody. This is Harry Frydenberg, and I'd like to welcome all of you, of course, to the virtual Ifso APC Congress. Obviously, this is our first Ifso virtual conference for the APC. Now, I would like to present the Isao Kawamura Memorial Lecture and to introduce you to Isao Kawamura, who unfortunately passed away in 2019. But he was a leader. He was a professor of surgery at Sakura Medical Center. He graduated from the School of Medicine at Chiba and his internship at the Chiba University Hospital, and received his PhD, and then did a stint at the Harvard Medical School. Professor Kawamura performed the first bariatric surgical procedure in Japan in 1982, and he led the Japanese Obesity Surgical Society and held an international meeting in Kyoto, which a few of us did attend. It was really quite an event in 1992 then. He was a professor of surgery initially at Chiba University, then to Shimosaga and Kameyagaya in 2008. And he was deeply committed to Ifso. He took part in all the Ifso conferences, and he was a teacher to young Japanese surgeons and mentored our present president of the Ifso APC, Dr. Kazunori Kasama. He also was the second president of the Asia Pacific chapter, and also someone who got involved in hosting meetings. And we had a meeting in 2004 for Ifso, and then an APC meeting in Wasutsu. And as you can see, we also did a little bit of skiing on the side. Unfortunately, he passed away in that same year. And here, together with a member of a few of the Asia Pacific chapter, you can see Kawamura. He used to enjoy everything. And here is a presentation of Mal Phoebe and Helen Phoebe to Professor Kawamura. His legacy is for you, the present and future Asian bariatric surgeons, to carry on his pioneering spirit, his involvement in Ifso and in Ifso APC. And this is the memorial lecture named after him for that reason. What I'm going to talk about today is bariatric surgery and the history of Ifso, but a little bit about bariatric surgery before the event of Ifso, because a lot of you have not an idea of what actually, when bariatric surgery started, but it actually commenced in the early 60s with Edward Mason, and you can see his photo up on the right there. Edward just apparently turned 100 years old, and he performed the gastric bypass procedures, following which surgeons commenced dealing with extreme obesity with Roux-en-Y gastric bypass, biliopancreatic diversion, of which Nicola Scopinara was one of the leaders, and jejunal ileal bypass operations. During the 70s and the 80s, international meetings were held on behalf by Mason and Scopinara, and this was what we call ISOS. It was the International Society of Obesity Surgery, and it was held in Genoa. And Mal Phoebe held meetings in America, in New Orleans and San Diego, and other meetings were held in London, Toyota, and Kyoto, which Isao Kawamura was the president of that particular meeting. And there was a meeting in Israel and Rapallo. I went to the Rapallo meeting in 1985, which was really quite significant. Just briefly, in the Asia Pacific region, in Australia, we commenced in the 70s with JIB. I did my first bariatric procedure in 1974. So I'm sure most of you, a lot of you weren't even born then, but that's the story. it was a JIB, and we started doing high gastric reductions or gastric stapling, which Michael Long actually started, and Andrew Jamison, one of our past presidents, was very prominent in doing. We then started open bandings, and that was Kuzmak, who had an open adjustable band. And the Adelaide group in Australia tried 3 different bypasses and found that the gastrogastrostomy wasn't particularly good. The gastric bypass was fairly good. And in 1993, Paul O'Brien and I attended the first laparoscopic workshop for gastric banding, or laparoscopic, like in Liège under Mitikul Belachev. We also in 1993, the international meeting of ICIS, the international group, was held in Echuca in Australia. And here you've got a few photographs of Nicolas Coppenaro trying a didgeridoo with an Australian sort of instrument, Mel Phoebe giving a hand at singing. And in this particular one, all the Italians actually tried to sing, or did sing, Nissim Dorma. It was a fun night. I sort of led the run there. Let me see, more of that. And we all had a lot of fun at that time. Now, from 2002, laparoscopic gastric banding was the mainstream operation in Asia for a while, until the mid-20s, to be followed by bypass, of course, laparoscopic sleeve gastrectomy, one anastomosis gastric bypass, which is gaining a lot more credibility today, jejunal bypass, the SADI or the SIPS, whatever you do. Whereas in Europe and in USA and Canada, sleeve gastrectomy and bypass and BPD were more common, and more recently, as I said, the mini gastric bypass or the one anastomosis gastric bypass. So what about IFSO? When did IFSO get started? Well, this is, interestingly enough, is the minutes of the first inaugural meeting on Saturday, September the 23rd, 1995. And this was held in Sweden. Unfortunately, I didn't make that meeting, but Andrew Jamison, and as you can see, all the people here from Israel, from the Czech Republic, from Italy, Coppenaro, Naslund from Sweden, Andrew Garrido from Spain, Taquino from Italy, Mervyn Dietel and George Cowan, all were there. And this is what there, the decision was moved by Mervyn Dietel, seconded by Nicolas Coppenaro, that the meeting approves the formation of the International Federation of Obesity Surgery. And this is significant because these are the minutes of the meeting that started IFSO. And as you can see, this is quite a famous photograph. There's Nicolas Coppenaro in front, Andrew Jamison on the left, Mervyn Dietel, George Cowan. You'll see here Mitikul Belachev, Martin Freed, and others there. And they're all actually named on the left, as you can see, representing all the bariatric surgeons. When I went to my first bariatric meeting in 1985 in Rapallo with Nicola, there were 45 bariatric surgeons worldwide. Can you believe that? Only 45. Look at it today, and I'll leave that to Lillian because Lillian's following this talk. And Lillian Cow is going to talk about the future of IFSO and the future of APC. I'm sort of stuck in the past a little bit, but there we are. So IFSO was founded in 1995, and the first IFSO meeting was in Prague in 1996, which I actually went to, and the first president was Nicolas Coppenaro. And the aim of the meeting was to bring together surgeons and allied health professionals for the optimization for the treatment of the severely obese. Now, the past and future world congresses of IFSO and the presidents of meetings. The first one, it wasn't really an IFSO meeting, but it's where IFSO started, was in Stockholm, followed by Prague with the 375. And as you can see from the numbers as we go down, Mexico, Bruges in Belgium, Salzburg, Genoa in Crete, Sao Paulo in Brazil, Salamanca, Tokyo and Maastricht. And these are all the presidents of the meetings at the time. But there are around 400 there. Then we had one in Sydney in 2006, in Portugal, Cancun, Mexico, Buenos Aires, Capri, Paris, Long Beach, Hamburg, Delhi. And at Delhi was very significant because we had the Dalai Lama who came to the meeting, and most of us got a chance to meet the Dalai Lama. Istanbul, Montreal, Vienna, Rio de Janeiro, more recently London, Dubai, last year in Madrid, and today we had a virtual meeting this year. Unfortunately, because of COVID, all of us had to go online via Zoom. Future congresses, and I'm sure that Lillian will talk about these. But we're supposed to have the meeting this year in Miami, but it's been put off till next year, and therefore the other meetings have all been put off for another time. So the presidents of at the different times was Nicholas Copenara, George Cowan, Emmanuel Hell, and as you can see, Australians are represented with Andrew Jemison, Martin Freed, and Jack. And as we go through the list, all the countries are represented. From Mexico to Malfobi, I did it. I was president back in 2009. Charlie Miller was in Austria. And as you can see, we go on to Kelvin Higa, Joaquin Benzamino Ramos, and our president of Ifso, Lillian Cow. And you'll notice that she's got a longer term because of COVID. And you'll notice that she's got a longer term, 18 to 20 months to 32 months. So she's going to have a very long stint. But can I say how well she's really done that? She's been doing it fantastically. Now, going on to Ifso APC. The APC it came about around in 2010. I was president of Ifso, and I thought that it's time that we have a local Asia Pacific chapter. There was a lot of discussion, and I spoke to a lot of people by phone, by internet, etc. But it was the APMBBS, or I think it didn't have the M in it then, was the local Asia Pacific Bariatric Surgical Group at the time. I had to fly to Kuala Lumpur, where I met Chaubi and Kawamura and Vijay Lee and the local Malaysian president, I can't remember his name, but to negotiate to commence the formation of the Ifso APC chapter. There'd been a lot of discussion before about it, but there was nothing concrete. It took this face-to-face meeting to allow this group to trust the Ifso proposal to form a chapter, which was to include APMBBS, which still has a close association with Ifso APC. Ifso APC is now a major part of Ifso, as you can see, one of its 5 chapters. So here are some of the presidents. As you know, I was actually the foundation president back in 2000, well, actually it was 2009, I think. And Kawamura, Isao Kawamura was the next one. Chaubi was the next. And this was a 2-year presidency because the Ifso APC meetings were every 2 years, and therefore our presidents ran for 2 years. And the Vijay Lee and Lillian and Mufi here on the right bottom corner, as well as our present president, Kazunori or Kazu Kasama, who's smiling, and CC1, who is our president-elect for the future. Now, we've had a number of different APC meetings. The first one was a combined meeting with the Australian Obesity Surgical Society of Australia and New Zealand and held in Cairns in Australia in 2009. It was a combined meeting and it was very successful. We had a number of people from the Asia area. But when we went to Japan in Rizutsu in 2011, it was very successful because we all enjoyed the skiing and that was really quite fun. Again, Kaohsiung with Vijay Lee in 2013, Korea with Dr. Choi, which was a wonderful meeting there in Korea, and followed by Shoshank Chah in India, in Goa, in Guangzhou with CC Wang, and in this year we've got a virtual congress. We were supposed to be, unfortunately, in Sri Lanka, but that didn't come about, and I'm not sure whether we're going to be there 2021 or 22, so I put that there, and Lillian will probably talk about that as well. So that's a brief history of Ifso and a brief history of Ifso APC. The organization now is very much bigger, and I'm sure Lillian again will go and talk all about it, all of its chapters, all of its members, etc., etc. And just to say, in order to know where you're going, you have to know where you came from. So I was able to give you a small insight into the origins of bariatric surgery, the origins of Ifso, and the origins of Ifso Apc. Enjoy the rest of the virtual congress. Thank you.
Good evening and welcome to the Ifso Apc Virtual Congress. I am Lillian Cao and I'm most honored to be giving the inaugural lecture in memory of Professor Niccolo Scopinaro, who passed away on October 23rd. For those of you who have met Professor Niccolo Scopinaro, he was many things to the bariatric community. But most of all, he was known for being the surgeon who changed the course of bariatric surgery. Professor Niccolo Scopinaro was born on the 6th of March, 1945 in Castagneto in Tuscany, Italy. He was a graduate of the University of Genoa Medical School in 1969 and became the assistant professor there in 1971, associate professor in 1983, and in 1992 was professor of surgery at the same University, Genoa Medical School. One of his most known achievements was that he was the originator of the biliopancreatic diversion procedure. He conceived this very original operation from laboratory experiments in dogs and applied the principles to human application. This operation, which carries his name, was quickly adapted in many countries. He was an enthusiastic surgeon. He was a respected innovator. As an invited speaker, he traveled all over the world. He also traveled extensively in Europe and particularly in Italy as well, either by car, and he used to drive a classic Porsche 911, or he also used his own airplane. Many of you may have known that he survived 2 dreadful episodes of accident, one when he was parachuting, another few years later when he was driving his car. He was known for his dedication, for his extraordinary vision, his warm heart, and was a great teacher to many and revered mentor for many surgeons around the world. He was also known as the father of modern bariatric surgery. In his lifetime, he performed more than 3,500 bariatric and metabolic surgery operations. He was a keen publicator and he has more than 500 publications and has given more than 700 invited lectures globally. He was the founder and honorary president of the Italian Obesity Society. He was the first president and honorary president of Ifso. He was also the first president and honorary president of Ifso, the European chapter, the first honorary member of the ASMBS, and also the first honorary member for many national obesity societies, including France, Japan, Greece, Turkey, Brazil, Spain, Germany, Austria, South Africa, and Egypt. He was the past editor-in-chief of Obesity Surgery, and in 2006 received the Foundation Outstanding Achievement Award from the ASMBS. On the day that he died, Dr. Paolo Grosso posted this: if you are lucky enough to have known him, if you had the intelligence to know him well, it could only change your life. So, ladies and gentlemen, I am most honored to be giving this inaugural lecture in memory of Professor Niccolo Scopinaro, the surgeon who changed the course of bariatric surgery. And may his legacy be for all bariatric surgeons, present and future, to remember him and to continue his fighting spirit. So Niccolo Scopinaro, the great man, the true professor, and the fighter, would like all of you to keep your eyes on the stars and your feet on the ground. It is my pleasure to present to you the present and future of Ifso and Ifso Apc. First of all, I'd like to give you this slide which shows the vision and mission of Ifso. The vision being to optimize the control of adiposity-based chronic diseases. And the mission of Ifso is to unify the global, scientific, surgical, and integrated health communities for the purpose of dissemination of knowledge, collaboration, and establishing universal standards of care for the treatment of individuals with adiposity-based chronic disease. Ifso now has 10,000 members coming from 69 societies and 5 chapters. The 5 chapters, of which I'm proud that I belong to the Asia Pacific chapter, of course the Middle East, North African chapter, the European chapter, Latin American chapter, and the North American chapter. Today we celebrate the virtual Congress of Ifso Apc, which has 843 members, 13 societies, and what is significant is as a chapter in the Asia Pacific, we represent 60% of the world population. So I thought I'll explain to you, what does Ifso do? Many of you say, what does big Ifso do? So I'm going to tell you about Ifso and how Ifso functions. To start off with, there are 10 committees that make up Ifso: the Board of Trustees, the Executive Board, the Scientific Committee, Communication, Integrated Health, Ethics, Bariatric Metabolic Endoscopy, the Registry Committee, Corporate, and the Nomination Committee. And I'd like to briefly tell you the function of each of these committees for you to understand how Ifso works. So let's start off with the Board of Trustees. The Board of Trustees consists of all past Ifso presidents, of which there were 22. The chairman being Luigi Angrisani from Italy, Vice Chairman Jan Grief from the Netherlands. In addition to all the past presidents, there are 3 other members, which is the current Ifso president, the Ifso president-elect, and the Ifso secretary-treasurer. The Board of Trustees is the overseer of the organization. This is important because of their membership. They hold corporate knowledge since 1995, and hence they have the role of ensuring that the core values of Ifso are maintained and that the purposes of the organization are preserved. We then have the Executive Board, which consists of the President, President-elect, the 2 past presidents, the Secretary-Treasurer, of course the Chairman from the Board of Trustees, all chapter presidents, and the member at large from all 5 chapters. There's the Integrated Health President, the Editor-in-Chief of the Obesity Surgery, the President of the Congress for that year, the historian, and of course the Chief Operating Officer, as you all know, is Manuela Manrella. The Executive Board is responsible for running the organization, for preserving the mission and the vision, and to assist and oversee all committees. From the APC chapter, we have, of course, the President, Kazu Kasama, and the member at large, Dr. Seng Ho Choi, representing the Asia Pacific chapter. On the Scientific Committee, the chair is Miguel Herrera from Mexico, and the mission of the Scientific Committee is to ensure that members have access to the latest evidence-based information. This is to look at position statements by systematic review, update the Ifso website, and the scientific program of the annual Congress. On the right, I'm just going to show you who are the members, and certainly Asia Pacific is well represented in red. Now, in 2020, Ifso issued a number of position statements, in fact, 6 position statements, the first of which, the Endoscopy Committee position statement on the practice of bariatric endoscopic surgery during the COVID-19 pandemic. The second statement was, how are we going to restart elective bariatric and metabolic surgery after the peak of the pandemic? And there were Ifso position statements on the role of endoscopy prior and after bariatric and metabolic surgery procedures. Also the position statement on Barrett's esophagus and bariatric metabolic surgery, which has been submitted for publication, and the update on 2 procedures, the SADI and the OAGB, which has been submitted for publication. We also endorsed a number of publications, namely the Joint International Consensus Statement for Ending the Stigma of Obesity, the BOM Summary Guidelines on Psychological Support, the ASMBS Position Statement on Weight Bias and Stigma, and the BOMS Guideline for Psychological Support pre and post bariatric surgery. As you know, the World Congress is an annual event of Ifso, and it has been occurring since 1996, except for this year, 2020, of which it was a virtual Congress. As you can see on the right, the numbers attending the Congress continue to increase. And last year in Madrid, we had 3,150 people attending. And we anticipate these numbers to be increasing, and therefore the role of the scientific committee is huge. It's a responsibility to design the program and carry out the scientific program for the World Congress. And we hope to have the World Congress meeting next year in Miami, August 2021. Next is the Communication Committee, which is chaired by Ahmad Bashir. The Communication Committee has the mission to improve member access to Ifso offerings to optimize the control of adiposity-based chronic diseases. And it is their vision that through electronic communication to improve dissemination of knowledge, collaboration, and help bring the global membership closer to each other and to Ifso. And how they've done this is through monthly journal clubs. They've also got the Ifso YouTube channel, Ifso mobile app, and of course, the webinars. And more importantly, also to collaborate with the World Obesity Federation, the ASMBS Communication Community, the International Diabetes Federation, to collaborate on even the webinars and joint webinars. What we've done also during the pandemic, the Communication Committee has been very active in presenting 8 webinars on COVID-19. I'll just share with you what these were. On April 9, we gave our first webinar on COVID-19 with the topic Worldwide Impact of Coronavirus in Bariatric Surgery. It is well attended, as you can see, and is also sponsored by different companies. This one was sponsored by Johnson & Johnson with $5,000 US. The second webinar was on emergencies and management options within different disciplines. This was on the 22nd of April 2020. This was a combined effort with AIS, and therefore there was no sponsorship here, but we drew, because of AIS, we drew 34,000 attendees to this webinar. The third webinar, we looked at the risk of laparoscopy and laparotomy in COVID-19 patients. We had over 1,000 registered, nearly 600 attended. We also had sponsorship money of $5,000 US. What you'd be wondering is why the numbers attended were less than the registered. Well, understandingly, this is a world webinar, and therefore people who have registered may not have been able to come on, but those who have registered can then go and listen to the webinar after it's been held on the Ifso YouTube channel. The fourth Ifso webinar was Maintaining Skills and Training Process Through COVID-19 Pandemic. This was on May 7, 2020. The fifth one was on May 21st, looking at restarting bariatric practice within the COVID-19 pandemic. We had good sponsorship on this one, and we had a $10,000 on this particular webinar. The sixth webinar was Enhancing Bariatric Patient Experience During COVID-19. Again, good registration and attendees. The seventh one was a bit different. We looked at the perfect sleeve gastrectomy, looking at everything that you've been afraid to ask for. And our final one was Enhancing Uptake of Bariatric and Metabolic Surgery in July 23rd. We also have the Integrated Health Committee, which is chaired by Mary O'Kane, which is a dietitian from Leeds in the United Kingdom. And their mission is to provide integrative support to optimize long-term outcomes to patients. What they've done is looking at postgraduate courses for Ifso. They've done a cookbook. They also do webinars and promote behavioral health and nutritional guidelines, as well as lifestyle changes. The members are on the right-hand side, and it is in Asia Pacific. We have Andrea Schroeder from New Zealand representing the Asia Pacific chapter. The Ethics Committee is chaired by Kelvin Higa, and the mission is without prejudice to deal objectively with any ethical issues that may have arisen. I'm glad to report that this is not a very active ethics committee. They have not had to deal with any ethical issues so far as I know. Then we have the Bariatric and Metabolic Endoscopy Committee, which is chaired by Baram Abudaye from the United States. And the mission is to develop and promote bariatric endoscopy as an interface between therapeutic endoscopy with bariatric surgery. And the vision is to provide endoluminal support for primary obesity and for surgical complications. Again, the members who are part of this committee is on the right-hand side, and you can see we have two members representing the Asia Pacific chapter in this committee. The registry is chaired by Wendy Brown, and the mission is to build on the Ifso Global Registry to improve clinical practice and outcomes on bariatric patients worldwide. This was started in 2014, and we continue to build on this. And there are many goals out of this registry to identify core outcome measures, looking at current data from global societies. And we have a strong members in part of this committee, which is also represented by people all over the world, represented by all chapters. As you can see, in Asia Pacific, it is represented by myself and John Dixon, with Wendy Brown from the Asia Pacific chapter. One of the outcomes of the registry, of course, if the Ifso Registry Global Report, the last one was in 2019, released in Madrid. And we hope to release the 6th Ifso Global Registry Report next year in Miami 2021. And this will hopefully have the attainment of aggregate data from national societies, not individual data, be able to identify core outcomes and to review the data dictionaries from around the world. We also have a nomination committee. Now, the nomination committee has got 6 members: the president, the board of trustees chairman, the president-elect, the past 2 presidents, the honorary president, of which we have now passed away, and of course, we have our chief operating officer. Now, the nomination committee is responsible for nominating the president-elect and the secretary treasurer, and to present the 2 nominees to the executive board and also to the general council, either for approval or for discussion. So this is a nomination committee that does not take it lightly. They look at people around the world to see who is suitable for these two positions. So that is how Ifso function. And my next part of the talk is to talk about the future. What is the future for Ifso, how I see it, and what is the future for Ifso APC to play within Ifso. What is exciting is that while Ifso got 10,000 members, the APC chapter has a lot to catch up. We only have 8.43% of the membership. We do have 20% of the national societies, 18.8, which is roughly about a fifth. But remember, we represent 60% of the world population. Therefore, the Asia Pacific chapter has got a lot to offer and to participate within the Ifso community. The future plans for Ifso and all chapters are included in the plans, including the Asia Pacific chapter. Many of you have heard about the e-learning that I've been talking about for bariatric surgery. I'll come back to that. There's a SADI consensus meeting which has been postponed from April to October to maybe next April. And then we're going to talk about Ifso guidelines and a collaboration that I find very exciting with WGO. So let's start off with the e-learning for bariatric surgery. This is a basic course for general surgeons interested in a career in bariatric surgery. So it's like a bariatric surgery course, a 101 course to prepare them for the clinical experience or the fellowship in clinical bariatric surgery. So the outline is really the basics, the surgical anatomy, the physiology, the procedures, nutrition, technical complications, to name a few of the topics. This is an interactive online course that they need to pass. There will be questions and MCQs that they have to at least get to a certain pass rate. And if they do pass, they get an Ifso certificate of completion as a competence certificate that they can present to a fellowship or a hospital to say that they are ready for their next stage, which is the clinical fellowship in bariatric surgery. So this has been an Ifso partnership with Ethicon and AIS. We're going to use as a platform to launch this e-learning. I'm happy to say that we are nearly there. We're probably about 80 to 90% completion. We hope to launch this in the new year and certainly be offering it to members from all chapters. The SADI consensus meeting, which we hope to have held in April this year, is very similar to the OAGB-MG meeting we held in Hamburg last year. This is an Ethicon partnership and therefore was held in the Ethicon Hamburg Institute. It has been postponed twice and hopefully we are able to have it sometime next year, if not in April. This is a consensus conference. We will usually invite 52 delegates as we did for the OAG consensus meeting from 5 chapters. These are the experts and the opinion leaders. We'll go through a Delphi process and come up with some consensus opinions from around the world. We were also going to partner with the World Consensus Meeting on Standardization of Management of Bariatric Complications. The first meeting was held in 2018 in New Delhi. Many of you would have heard of this meeting and some of you have attended this meeting. The next one was meant to be April again this year, and this has been postponed twice. And this has the aim of managing complications unique to bariatric surgery. Again, delegates from 5 chapters, experts, opinion leaders, a Delphi process, and this is a combined effort with Ifso as well. Ifso guidelines for bariatric metabolic surgery. Many of you know that the NIH guidelines, which were published in 1991, is most outdated. It was written 30 years ago and was written for open operations. So the aim is for Ifso to revise these guidelines to suit the current environment. A task force has already been built by Scott Shikora, and there will be delegates from all 5 chapters. Some of you have already been invited, and hopefully we will come up with some guidelines, IFSO guidelines, that will stand to help us through the next many years for bariatric and metabolic surgery. And lastly, we've had a collaboration that has been in process. It's with the World Gastroenterology Organization. This is an organization of 110 member societies. It's the federation, very much like IFSO, but they have 4 regional associations, but much bigger than us. They have 50,000 individual members worldwide. Their focus is a bit different. They focus on improvement of standards in training, in education, in the practice of gastroenterology, hepatology, endoscopy. And it is a focus on the low resource nations. So it's an initiative on education to train people around the world. They have public awareness campaigns. They have a World Digestive Health Day and global guidelines. So they partners with us on their yearly topic for 2021. Their past topics this year was on gut microbiomes. In 2019 was early diagnosis of cancers. And so IFSO and WGO will come together for 2021 to update the guidelines for obesity. This is an equal and joint branding with them. And we hope to come up with some practice guidelines, which will be translated to a number of languages around the world. So this is an exciting collaboration that I'm very excited about. So these are the future plans that is for IFSO and for Ifso APC, and I will welcome anyone who would like to be part of this to put up your hand, nominate yourself, tell any one of us that you like to be involved, and we certainly welcome your participation within the Ifso APC as well as within the Ifso committee. And once again, thank you very much for inviting me, and it is my pleasure to be part of the Ifso Virtual Congress, and it is my privilege to give the first Scopinaro Memorial Lecture for Ifso APC. Thank you very much.
Hello, everybody. I want to thank first the invitation from all my friends for Ifso APC, Kazu, Harry. I hope I can see you soon, guys. But in the meantime, this will do what I know it's going to be a very successful meeting. This is some of the disclosures I have for the presentation. How technology that we have looks like today. So in a few years, we're going to see that the technology we're having now is going to look like this. Yes, we are very resourceful with what we have. We can use what we have, even if that is not the perfect technology we want, the best procedures, the best devices, but we still be able to do what we have to do. But also there is room to improve under certain conditions. First one, safety. Real safety. You cannot do anything that is not very safe, not like this guy. Second, as you can see here, this is the other condition for me. It cannot be fake. It has to be a real device, real procedure, not something that somebody invented one day. And this is the other condition also. What some people are trying to do is bring very old procedures that didn't work, open or laparoscopic, and now because we can do it minimally invasive by endoscopy, we are coming back to those ones. We cannot do that either. So when you divide what's happening in the bariatric world with this intervention, we divide it in two. The one in the stomach, the one in the intestine. And we learned a long time ago that the one in the stomach are more related to weight loss, while the one in the small intestine are very, very more specific for diabetes and metabolic diseases. So let's go very quick to some of the intragastric ones, the gastric one. The balloon has been here for years. And for me, as long as you use it for short-term goals or cosmetic, like 6 months, and I have a wedding, in a year I want to go to the beach, with those one it works. With other ones, not that good. But some people try to keep them for more or put in more fluid. We did that. It doesn't change anything. Maybe this one will change a little bit in the future when you have the intragastric balloon that you can swallow. Maybe that will be easier and more accepted by the public. Aspire, the concept of having a gastrostomy that you can put fluid, blend it, take it out. The mental concept is not that good for us, but some groups are doing it and the patients are having satisfaction. What is the baby? Of course, is the ESG, the endoscopic sleeve gastroplasty, where using our suturing device, you can collapse the stomach like an accordion and getting results like these ones. We presented this long time ago. We started some of the first studies in the world. The results are not bad. Once you learn how to collapse the walls, greater curvature, anterior and posterior, your results are going to be pretty good. And we understand why. You see gastric retention up to 2,400 minutes after the ESG that we didn't have before. So that caused change in gastric emptying that helps a lot to the patient. Also, as you can see here, 5 different cities, 3 continents, the standardization of the procedure has been pretty good. We're doing some trials now, but more important, can you revise them? Yes, you can revise them, as you can see here. This is a paper we published with Mohit Bhandari, Galbao, and myself. When you review, you revise the gastroplasty to sleep with no problems. There is other procedures like this one from Lopez Nava that you do the POSI. They are starting the new studies now with modified procedure. We're waiting for the results, but this one maybe is gonna change the world. This is called endosip. And as you can see here, you put the instrument, you suck the whole stomach inside the instrument, and then you put the suture. And this is gonna look like a zipper like this one. And that's what makes it very, very interesting, as you're gonna see here. You introduce the device, it sucks the stomach inside, but a needle is gonna go through all the steps, and that's gonna take 10 minutes, and they'll be very easy to do. We're waiting for the first studies for them. Then let's move from the interventions on the bowel. Remember, this is much more metabolic, much more related to diabetes. Why? Because we learned a long time ago that if we prevent food to contact the mucosal of the duodenum, and also we are able to change the changes that it occurs for abuse of sugars in the small intestine, we're gonna get very good results. And we learn it from surgery. We know that the duodenal mucosa is altered by diets high in sugar. Then you get insulin resistance. So if you do something there, you're gonna treat better metabolic problems and diabetes. Some groups are doing in different ways. You remember the endobarrier that had some hepatic abscess in the US. It was canceled. They are starting again the trials. This is another one from the group of Rakesh Kalpala in the AEJ with the metamorphics. But the concept is the same. You prevent the food to get in contact with the mucosa of the duodenum. With that, you alter the composition of the mucosa. But some other people rather destroy it completely, like the DMR, duodenal mucosal resurfacing. You can do it with boiled water like this one. You lift it with silane, you burn it all, and as you can see, they come back. While you have it there, the results are pretty good. This is a video from some of the first cases done in the university. I also work in Brazil with Greco Galbao, where you lift the mucosa, you burn it, as you can see here. As soon as you finish, it all looks what you don't like to see in surgery, but here it's okay. And then the patient results are pretty good. And then when you come back a year later, the mucosa is back. And of course, the diabetes will come back. So the decision is you're gonna burn it again. But look at the results. Only in 12 weeks, hemoglobin A1C, more than a point down. HOMA-IR, 12 week, very good results. But this is more important. We notice the metabolic effect. Look at the fat in the liver, in the patient. The more light the color, the more yellow, dark, is more fat. In only 12 weeks, the hepatic fat content went very low and the fat in the abdomen went low. That helps a lot for the metabolic disease. But can you burn it all the time with water? No. Some people now try to do the same with laser. These are people from Israel. So they target specifically the submucosa and they create a circle around the papilla to protect it. Maybe you can do this more than one time. But people are doing the same now with some pills. This is Lucy. Lucy's luminal coating. So you get a pill, you cover the whole duodenum with a coating. The patient stay with no contact 8 hours, 10 hours, and then you take another pill. Maybe this will replace metmorphin and some other medication for diabetes. In the US, Glycine is already approved, and it does exactly the same. It's a polymer that will cover, and then you're gonna have some results. Also, when you regain weight and you get big anastomosis and you have big pouches, some groups are doing argon coagulator, some groups like ours are suturing, anastomosis of 2, 3, 4 centimeters, we make them again in 1 centimeter, and that seems to help for some of our patients. We published that in 2017, and the results are pretty good on stopping regain of weight and getting another 6 to 7% extra weight loss. But some people, especially in groups in Korea, are developing this kind of a stent that they are big in the outside, small in the inside. So what you do with them is you insert them in the patient with the bypass. So you not only reduce the size of the anastomosis, but you also added that component of malabsorption or reducing the absorption in the duodenum, and that will be pretty good. Next, we move to magnet that you can put by a scope when you can create anastomosis with no bleeding, no leaks. They open by themselves. You can do this as an outpatient. I think we ended up doing most of this anastomosis in the future with magnets. If we can prevent leaks and we can prevent not having any other problems with anastomosis, that will be great. Easy to deploy, very nice and safe anastomosis that will replace some of the anastomosis that we do today. Finally, in the robotics, many platforms, many different, with good quality, enough triangulation for us, very fine movement. This is something that I think is going to change the world of endoscopic intervention, and they are very close, at least 10 different companies doing this. Like you can see here, this is a resection, but most important, even if you go all the way to all the layers, you can suture very well like you can do in surgery, and that is what's going to change it. So as conclusion, first one, primum non nocere, kill as few patients as possible. You don't have to be the first one, you just have to do it safe. Second, don't compare this with the SADs, with the BPDs, because this is interventions, temporaries, for so many patients that will benefit from this, and you can do many interventions in life. Finally, who's gonna be doing this? Bariatric surgeons or GIs? It will be my answer. Whoever does it better. I don't care who does it, as long as it's the best person to do it under control with multidisciplinary group. In conclusion, we're gonna reach much more people in need, even if remissions are temporary and you need new or reinterventions. Thank you very much, Guy. Enjoy the meeting.
Hi, hello everyone. Nice to see you here. So my job today is to describe the bariatric technology in Asia perspective. And this is my disclosure. And I must say that I have done quite a bit of endoscopic therapy and also gastric stimulation therapy during the past years. If you look at Asia, 15 years ago, we have only 3 countries perform open bariatric surgery. But actually, thanks to the bariatric technology with invented laparoscopic gastric banding, more and more Asian countries are start to develop bariatric surgery, and this helps us in this area a lot. But this development is still not enough. We are still underdeveloped markets, but we do have a large population, especially in China and India, and our problem of type 2 diabetes is increasing. If you look at the audit on Asia, like China, Taiwan, and India, more than 30,000 cases were performed each year, and actually altogether generate about 1/4 of the revenue of bariatric surgery markets. So this is a huge development, and this need to be taken care. But we do have problem in Asia, especially we still have a low intake of surgery because Asia people are still worried on the risk and side effect of surgery. Another issue is the cost, because most of the Asian countries do not have an insurance system who cover bariatric surgery, so people need to pay by their own pockets. And so we are looking for something cheaper and less invasive more the time. If you look at the main brand of bariatric instrument, they come from this big expensive company, but which cost less development in Asia. But thanks to China, the imitation and development of technology had gave them a head start of more developing different stapling or device company, which have a much lower cost. And now this company had helped some of these Asian countries to develop their bariatric surgery. On the other hand, we are looking for safer surgery with the advancement of technology, especially like endoscopy or electric stimulation. Electric stimulation or moderation is interesting because if you give high frequency, you can get a blockage of signal. But if you get a right frequency, you can get stimulation. So V-block is a kind of vagal nerve blockade by high frequency, and it has been adopted in Asia, mainly Australia, together with US. Actually, they help them to get the FDA approval for this device. On the other hand, this another gastric stimulation device called tetanus have been tried in Hong Kong in diabetic patients too. But at the end of the day, this kind of electric stimulation or moderation is not that promising. More promising, especially in short term, is endoluminal treatment with balloon. In Hong Kong, we introduced it since 2004, and in a series of 100 cases, we approved this device is as effective as in the Western country. So after that, many more Asian countries have started to have this balloon treatment. But of course, balloon has evolved itself, and with the technology now, we can have a balloon that we don't need endoscopy to insert, and they can pass out themselves. It is the ellipse balloon. And in recent data, we can see that it is a similar efficacy in weight loss as the previous endoscopic insertion balloon. At this moment, most of this series is in Europe or in America. But in Asia, we do have 3 countries, which is Hong Kong, Singapore, and Malaysia, that have provided ellipse device. But no matter it's ellipse or balloon, you can see that China actually do not have this device all these 50 years. The reason is China FDA is very strict, and different countries have different criteria or restriction of implant or development technology to import it. Hong Kong, on the other hand, is the loosest. You can get anything in without registration and you can put it immediately. So different countries need to be aware of their different criteria. Some can introduce earlier. So apart from this temporary endoscopic placement balloon, nowadays more and more devices are coming up. And the one that most astonishing is the overstitch, which that you can use this to create the endoscopic sleeve gastroplasty. And now we have more and more data show that it is not just effective, but also more durable. And 5 years outcome is coming, seems that they are very promising. But do you know this device actually come from Asia with Apollo group from Olympus and development in Hong Kong, this Eagle Core, which is a device before. And this initially used for hemostasis. But now, Hong Kong, not just Hong Kong, but other countries like India, Malaysia, Australia, and Taiwan are start to do this endoscopic sleeve gastroplasty. But the problem with this procedure is they had long learning curve, and this is not easy and need to be very skillful. But thanks to the endoscopic technology in Asia, actually we are starting to develop different technology, especially in robotic endoscopic surgery. And in Singapore, we are doing, you see this Endomaster device. And in Hong Kong, we also have the center in Chinese University had developed a new endoscopic robot, which in the future, not just doing ESD, but also this device is planned to develop suturing as well. So ladies and gentlemen, may I conclude, bariatric technology is important and is high demand in Asia. Asia still have a problem of cost or invasiveness of procedure. So when this technology want to come to East, Some country may have restriction, and us in the East, we are mostly developed, especially in the endoscopic therapy, because we are strong in this area. So thank you for your.
Hello and greetings to all. It's a pleasure to join you virtually for the Ifso Apc Congress. And I will be speaking today on promising technologies, East meets West, robotics and magnetics in surgery. These are my disclosures. The only which is pertinent is I am a consultant to Levita, which makes a commercially available magnetic device. So progress in minimally invasive approaches to metabolic surgery is central to what we do as metabolic surgeons. And from the progression to open procedures to laparoscopy and the burgeoning realm of endoluminal therapy, we have a lot of new options in minimally invasive surgery. I'm going to talk about two today, magnetics and robotics, and how we can combine these to treat our patients in less invasive ways. So it's a quick dive back into technology progression and certain technologies that have improved or have really not had much traction in our fields. And these include single incision laparoscopic surgery and nodes, which to varying degrees are still practiced within metabolic surgery and outside of it. There are robotic single site technologies, and we published on this several years ago with the first in human patients, but the reality is this didn't have a significant impact on our practices and hasn't been as enthusiastically embraced as we might have thought. There are also mini laparoscopy devices which allow for percutaneous procedures, but I'm going to talk about devices that leave no incisions whatsoever. This is the deployable magnetic surgical system with a device that allows for implantation of a detachable tip that acts as a grasper for manipulation of organs. And in addition to standard laparoscopy, an external magnetic controller allows this device to move within the peritoneal cavity. And we published on this in Cleveland with the first US experience for cholecystectomy, and subsequently published this in surgical endoscopy. And this has been mirrored in other publications from different groups as well. But I want to talk about how this can be applied to metabolic surgery and specifically to sleeve gastrectomy, but you can also think how this could be applied to other laparoscopic operations. I just think it's compelling because sleeve gastrectomy is the most common procedure being performed in many countries worldwide. And one of the central components of this is visualization of the stomach and retraction of the liver. And there are many different laparoscopic devices that we use for retraction of the liver and better completion of the operation safely, especially at the esophagogastric junction and the left cruce of the diaphragm. So with the deployable magnet, this grasper can be attached to the liver for visualization of the stomach. So this does not require an additional trocar, and it can allow for repositioning multiple times over the course of an operation to expose the area currently being operated on. And a group from Duke University published on this, looking at magnetic liver retraction in incisionless approaches to liver retraction, and specifically for bariatric surgery. It's a small cohort of patients that you can see here, similar to our other bariatric surgery patients, with relatively easy use of the device and no adverse events. But importantly, they looked at other postoperative results, including external abdominal wall evaluation, 6 hours post-op, and thankfully there were no serious adverse events and one trocar site bleeding. And this prompted other groups to look at postoperative pain using the magnetic device instead of a liver retractor, and there may be some difference at an early time point, though this may not be as compelling longer term after the operation. And this could even be seen to reduce the length of stay in certain operations, again from the Duke University group previously published, looking at sleeve gastrectomy, bypass, and duodenal switch. And then in a survey of patients, looking at potential magnetic surgery, cosmesis after surgery was deemed to be very important for those patients, and maybe eliminating a scar in addition to decreasing pain could be very compelling for these patients. So how do we combine deployable magnets with other technologies like robotics? So this is a robotic arm that can be deployed and manipulate the magnetic internally. We have now published on the first human experience of the magnetic robotic controller as an accessory to the magnetic surgical system in reduced port cholecystectomy, a small group of patients with primary outcomes of safety and efficacy. So what does this look like in a model? This is the deployed magnet, obviously in an ex vivo plastic model showing manipulation of a potential target organ. The robotic device is controlled either in the sterile field or off of the field to allow manipulation with real-time changes for visualization. And this could be used on the liver or on the stomach for retraction during bariatric surgery. So what do we find? Again, in a small group of patients for cholecystectomy in this published series, expected operative times, no complications, and all patients were discharged within 23 hours. This is a quick video of what this looked like in real time with manipulation of the gallbladder and simultaneous laparoscopic dissection. The robot is sterile in the field and can be adjusted by the surgeon as needed, and this could facilitate exposure to the stomach as well, and future studies will be also targeted on bariatric operations. We found no interference with other equipment, and overall surgeon satisfaction was high, and patients did indeed have a desire to have magnetic surgery as well. So clearly this is a limited experience, but it demonstrates early safety and efficacy, and this could be a platform for other more complex procedures. And this has been accepted for publication. So in conclusion, in my brief talk today, innovation remains central to metabolic surgery progression. Less invasive techniques may be unique to particular populations, and the use of deployable magnetics in potential combination with robotics may give us even more cutting-edge technologies to perform these operations in less invasive ways. Thank you very much for your attention.
Greetings. My name is Manuel Galvão Neto, and I'm here from Brazil to present to you about the endoscopic gastroplasty as a promising new procedure. And first, I'd like to thank very much for the invitation. I'll try to do my best in this 5 minutes. And this is my field of interest, is bariatric endoscopy. It's the team I'm proud to work with in Brazil. And the idea is that we're gonna use this endoscopic suturing machine. First, it was mounted over a double channel scope, now have single channel scope. The idea is that you can do full thickness suture in the different standard of fashions of how to do it, and working in the greater curvature of the stomach, anterior greater posterior wall, and then tying that, modifying the anatomy in the stomach. As you can see here in the cartoon, we can see here a real case. We have this corkscrew-like called helix. We go into deep muscular layer, we bring tissue, we close the suturing device to exchange the tip of the needle, and with that, we go to one side to the other and can do different standards of suture in a very fashionable and standardized way. And this is what we achieve. You can see the stomach before, and you can see the stomach just after in this three-dimensional tomography intraoperative. So we really want and aim to reduce the body, not the antrum, a little bit of the fundus. And this is a very small video of a procedure just finished. As you can see here, we are able to modify the anatomy on the greater curvature, tuburizing and reducing the size of the greater curvature. That is clearly demonstrated on this video on your screen, and how it works. So we have some data showing that's a very fresh data from the randomized control trial, the preliminary results that we are doing in US right now, that we have the controls and the ESG subjects, and you can see here in this randomized fashion that we impact on the gastric emptying on the group that we do the endoscopic suturing on that. This is a brief timeline that you can see starting 2012, first series, and then European series, American series, then we combine them together, multicentric study, and just in 2016-17 have the very large first series of 1,000 cases come from Saudi Arabia. And as we speak, we are producing level 1 evidence on US, and very recently we published the Brazilian consensus of ESG. More than 70 papers were done over this matter up to now, and besides being a very new procedure, is very promising in a way that we can produce literature like these, the Brazilian consensus 2020, 1,828 patients with 18.2% of total body weight loss up to 1 year, more than 47 endoscopies with 15 years of endoscopy condensed, 87 cases per patient, all trained in a very standardized fashion on the U-shaped suture. You can see here the suture is more used as U-shaped and square. And you can see here, that's important. Almost 2,000 cases and less than 1% complication. And you can see here some bleeding, prolonged pain, persistent vomit, 3 very severe complications among that require laparoscopic intervention, 2 abscess and 1 gallbladder puncture, and the very first published death that occurred on this procedure due to pulmonary embolism in a high-risk patient. So long-term data, we have this paper from Cornell, 5 years of follow-up. So at 5 years, a very good follow-up, 89%, and those patients reach 18.7% of total weight loss, and the percent of total weight loss was 14.5%, and important, 70% of those patients at 5 years with at least 10% of total weight loss. They have 3 severe adverse events, 2 bleedings, and 1 perigastric collection with conservative treatment on that. And this is the graph of weight loss, as you can see here, up to 60 months. And also, we know now how we compare with the other procedures. So it's from Spanish group, comparing endoscopic sleeve gastroplasty, laparoscopic sleeve gastrectomy, and the laparoscopic greater curvature plication done by robot. You can see here there's a clear advantage for the surgical side, but the weight loss achieved with the endoscopic group is not that bad, with 18.5% of total weight loss at 2 years. But when we compare in terms of complication with 0.5% over when compared with the surgical groups, there's a clear benefit to the endoscopic group, as well as the time that patients spend in the hospital, as you can clearly see on here, this slide. So again, as we speak, we're producing our level 1 data with prospective randomized control trial against diets. And you can see here by the groups that are participating, Mayo Clinic, Cornell, UT, Harvard, Hopkins, and much more of private centers, and we are producing this data. So I'll finish telling you that we have just 8 years, 15 to 20% of total weight loss is expected. It's safe. We have 1 to 3 year data, 1-5 data isolated, and we have around 15,000 cases done worldwide. And that concludes my presentation, telling you that really is a promising procedure that we are able to use in the clinical practice that we expect that benefit the patients with obesity. So with that, I rest, and I wanted to thank you very much, Ifso Asia Pacific, for the invitation and the opportunity to present our data.
All right, I'm here to speak about the role of endoscopic bariatric techniques in the light of weight loss trajectories. I've been interested in these topics for some years, new technologies, and above all, bariatric endoscopic techniques on one hand, and on the other hand, the study of the trajectories of weight loss, whatever the case, surgery, medical, etc. So, this is my case disclosure. I do mostly bariatric surgery and mostly sleeve gastrectomies, like many people do worldwide. So let us start with a fact that is not so obvious for many of us, which is the fact that although there are a lot of oscillations and namely weight cycling, there is a phenomenon of weight stability over the years in the general population and also in the obese population, meaning that the changes we may observe are quite incremental or with variations. This is a very important fact. And of course, these oscillations are interesting, but nevertheless, it remains that the fact remains that we have a kind of stability over the years in most of the population. And this is also the second very important lesson, is that we may achieve this kind of stability with surgery. And this is a very important lesson from many curves in bariatric surgery. For instance, this is a famous curve regarding laparoscopic gastric banding, also criticized at the moment. The second very important fact in this regard is that there are two kinds of population: the population that responds to a bariatric treatment and the one that does not respond or respond in a poor way. So it's very important to distinguish the responders and the non-responders after any kind of techniques. What about EBTs? It seems to be a reasonable compromise in terms of weight loss. And this is for many of our patients, at least the ones who are not suitable for surgery or do not want surgery. And this is the statement of the American Society of Gastro and Intestinal Endoscopy. You may disagree with most of this statement, but nevertheless, it's very important to know that for many people worldwide, these techniques are a very important option, a very important alternative. So what's the rationale of our suggestions? This is an important study, but I didn't pick it up because it's important, because it's very emblematic of what can be done nowadays in terms of randomization and prospective study. This is a study dealing with a balloon, one of maybe the most famous endoscopic technique and the most simple, by the way, and dealt with the balloon plus a low-calorie diet versus very low-calorie diet. And of course, the people who had the very low-calorie diet at 3 months, while the patient still had the balloon, did better in terms of weight loss 6 months afterwards. My suggestion is to do the other way around, so to speak. So meaning that if you have the GENCO's initial design, you may turn it the other way around and choose to start from the data and to consider the treatment, the most effective treatment, only in the population who did not respond. So this way of dealing with such a study may be called adjustable clinical design, and it brings the input is to have not to exclude the population who doesn't fit into the criteria that you usually admit, and therefore it might be more interesting in the future when you want to combine several clinical studies, including bariatric surgery, that may be also combined with endoscopic techniques and not surgery. So I don't have time to dwell on that, of course, but scientific evidence support the fact that there is a continuity between the population in terms of weight loss and response and non-response, and this can be modelized, analyzing, for instance, the area under the curve, etc. We suggest to build these sequential strategies with an adjustable clinical design based on the study of weight loss trajectory. So you start from the data, you don't rule out a given population that is motivated under the sole pretense that this is not fit. And of course, you may combine bariatric surgery with other bariatric techniques like endoscopic bariatric techniques. Thank you. I think it's all.
Thank you, all the speakers. So please join us, panelists.
Again.
Thank you.
I'll go
I
out.
really appreciate your lectures, and I'm very glad to know the history of Ifso, and also that we can share the brilliant idea of what to do as an Ifso member. It's a really very informative. And also we need to know about new technology, so that I would like to have some polls. So Manuela, will you send them polls? And during that polls, I would like to ask you about some questions. I still don't have any question from the audience, so that I have some questions to you. So regarding a new technology, what do you think is the most promising technology? So I'd like to have an opinion from our current president, Aurelia.
Thank you, Kazu. That's a very good question. Today we've seen the whole range of operations. Harry started off by explaining to us how bariatric surgery started with open and the laparoscopy. We've gone on to robotics and endoscopy. And I think for the future, there will be a mixture of all the techniques coming together. I don't think it's just robotic against the endoscopy or the laparoscopy. I think a combination of all those techniques are going to be very exciting for the future. Hybriding technologies together, I think it's going to be an exciting time.
Thank you. So what's your opinion, Harry? You know everything from the beginning.
Well, as you can see, there are endless sort of different combinations of endoscopic with magnets on one hand and all the other endoscopic techniques. Now, I can see that they've developed over the years, because at the beginning, ESG was thought to be, well, maybe experimental and to see what's going on. But with Manuel and the others showing that it's got a long-term beneficial effect. And I think you'll find that this is going to happen with a lot of different endoscopic techniques. Jerome, it's interesting to say what you were saying there. What I wanted to know from Jerome is, you talked about, you know, the responders and the not responders, because this is another area that we have to look into in bariatric surgery. But what is the relationship of motivation and results? Because I don't think anyone's done a really good study, and the endoscopic technique is a good way of sort of working that out. No one's psychologically gone in to find out the motivation of the individual versus the response and the results. So let's see. Oh, Jerome, put your mic on.
Jerome, you are muted. Jerome, you are muted.
We can't hear you.
Jerome, you are muted. So open your mic. No, it doesn't work.
It doesn't do it. Okay.
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 Ah, okay, got it. Yeah, that may happen. Thank you so much.
No, it's okay. I guess you have me.
Ah, good.
Oh, yeah.
Yeah, sure. So I didn't catch exactly the question of Harry. The relationship between the results and the psychological behavior. Was that your question?
No, the relationship of motivation versus results.
Yeah, of course. And my opinion, I think Manuel will agree with that, is that when it comes to endoscopic techniques, this is a more important issue than surgery, because we are dealing here with somehow lesser weight loss, so that motivation is more important than in surgery. But this is, in my view, you may disagree, of course, but this is not the most important issue. I guess the way to consider, there's a lot to talk about, of course, but the way to consider responders and non-responders is something that can unify bariatric techniques. Endoscopy on one side and surgery on the other side. That's the most important in my opinion. I'd like to have Manuel's opinion about that, but I think this is a very important issue. If Manuel can speak, I don't know.
Yep, I do can. I hope you're hearing me well. And yes, it is the whole idea is of on the early that one against the other. I remember the time of gastric band being up on no one's land, taking all the bullets This is nonsense. And now maybe we are understanding this chronic, progressive, incurable disease that is obesity. And we are obliged to offer a treatment for every step of the disease, as we do for diabetes, as we do for hypertension. And by the way, it's obesity that causes both. And that's the really nonsense from us. Weight loss, Kazama. I can achieve the same weight loss of surgery. Believe me. It's just using our endotherapies with combination with drugs. But they're going to be sustainable. What they're going to go for. So what we are seeing right now is pretty much understanding which of those treatments will fit on that. And we are very fortunate to see another endobariatric therapy comes to the light of clinical use, that is the endosuturing, because we just have one before, that is the gastric balloon, and now we have the endosuturing getting to the light and with very good safety profile, and we understanding it better. And what I see in the future is integration from what we all are doing.
Kusama, I was going to say, Simon, do you think in the Asia area that you'll be able to endoscopically operate on people of lower BMI?
I think this is a matter of inclusion by criteria and also patient acceptance. You see, at the era of gastric banding, it helped to push a lot of people feel bariatric surgery is very dangerous, to change the idea it is relatively safe. Although it may not last very effective long, but it changed the scope. So many people accepting bariatric surgery, especially in Asia. And now the endoscopic therapy are really doing the same thing, that when you start to do it, people are feeling that it is effective and it is very safe. And then it would also bring more people, because if you go out and ask, they have motivation of weight loss, but they are too scared. They don't have the guts to do it. So, but now you have something in between. I think that is the direction that help to expand the territory. And then some people within the endoscopic group may have seen more surgical patients in your field, and then they may have more confidence in surgery.
Thank you, Simon. The time is very limited, so that I need to have a poll to audience. So start the poll, please. The question is, will new technology change the current bariatric practice? It may increase the patient, but not the laparoscopic surgery. It may increase the patient and may reduce laparoscopic surgery. It may increase the number of patients and number of laparoscopic surgery. Or, no, it's just a fashion, no influence on current practice. So please vote it. So let me know the answer of the poll. Yeah, you can see the answer of the poll. So the majority of, well, that's good. It may increase number of the patient and also the number of the laparoscopic surgery. So that new technology, we have a new technology patient and also the laparoscopic patient, surgery patient increased. That's quite interesting result. So yeah, how do you think about this result, Nathan?
Yes, I'm glad the question. Sorry, it's very early. I'm just having my breakfast here in Miami. So I will say two short comments. The first short comment will be that according to what Harry asked before, I think we're going to ask a very different question in 2 years. It will be a timeline question. When these therapies will combine together to keep promoting the chronic intervention in obesity. So I think we're going to use a lot of them, different intervals, sometimes together, sometimes in a timeline. I think that that will be Harry's answer. For the poll, I totally agree with the 41%. I think hybrid things, I think, for example, magnets will be hybrid while they move to full endoscopy. I will say some of the endoscopic technology will work for some time, and then you're probably going to need a laparoscopic intervention and the opposite. So I think the numbers will increase for both, not necessarily only for endoscopy. And it's not a new fashion. You don't have 80 different technologies as a new fashion for years now. So I think it will be stay for long.
Okay, thank you, Nathan, for the comment. So I also like a comment from Matthew.
Hello, all. Congratulations on the session. I largely agree with everything that's been said. I don't want to retread what the experts have said, but I think it's interesting because it's largely what I see in practice too. You'll have patients that come in and may request a certain intervention, lifestyle, endoscopic, or surgical. And it's up to us, the practitioners, to decide what's best for them, knowing that this is a chronic disease, that over the course of their lifetime, they need multiple interventions that are endoscopic, laparoscopic, and medical, and making sure that we vet the technologies, that they are effective over some sort of duration. But I think that the takeaway from this session is that many of the interventional technologies should not be compared against surgical procedures, but they fit in the middle between medical and surgical intervention. So all of us are surgeons on this call. Sometimes we look at the outcomes and durability and say, well, it's not as good as X surgical procedure, but that's not the group of patients we're trying to treat. We have to be careful of that.
That's right. So that this is the time so that we have to conclude this session. Is there anybody who want to add some comment?
I will want to add that if this technology is going to help some place in the world, will be in Asia Pacific. You know, sometimes I consider it's too dramatic what we do here in the US for our big population compared what you should be doing there. That will be my final comment.
Thank you. Harry, do you have some?
Well, I was going to say, I think that, yes, the fact that the question, I think, came up whether it was going to be the gastroenterologist or it's going to be the surgeons that are doing it. It's an interesting question because in Australia, for instance, we're 5 or 6 states or different areas, and in some the surgeons don't do any endoscopy, and in others the surgeons do endoscopy. So it's obviously going to depend on what the natural sort of development in each particular country is going to do. Okay, Manuel.
So I think that just complementing what you just said, Harry, is that the burden is on us. We have the responsibility of training the new generations on the new technologies, especially as understanding that the flexible endoscopy is just a tool, as a laparoscope, that our specialty have to use liberally on both, on any ends. Laparoscopic, robotic, endoscopic is just a tool, and the burden is on us to bring to the Ifso all these technologies. And I also agree that with Nathan, that Asia Pacific will really benefit on those technologies because they can be applied in lower BMIs. As we can see here, that obesity it behaves very differently on your area of the world.
I'm going to tell you. No, sorry, Nathan.
Yeah. No, I just agree. I just want to say I agree with Madel that it is very important. No matter your surgeon or country that are doing endoscopy or gastroenterology, when you pick up bariatric, I think you need to learn endoscopy and bring it to your daily work, so that you learn the technique and you learn to deal with your complication and treatment and so on. So this is important for bariatric surgery and to develop.
I agree. I'm going to take a photo of all of you, but also I'm going to let you in. We are working on, Manuel, we are working on a gastroscope which is self-propelling, and it'll go all the way through the small bowel. Now that may be helpful. I'm just about to do some pig experiments with this scope, and we're going to, it'll make the pill cam obsolete. You'll be able to go through the small bowel completely, and it's self-propelling. So that would be good for your magnets there, Matt, and also the other ones. So more technology coming up.
We look forward to your results next year, Harry.
Well, we're going to try and do the pigs shortly. We're not quite ready yet.
Yeah, we have a lot of things to talk more, but time is limited. So that I would like to conclude this session, and I really appreciate all of you to join this session so that we have a future. Thank you so much. Take care. And please visit the exhibition area of the Congress and see our exhibition areas. And have a coffee break now. Thank you so much.
Thank you.
Thank you.
Thank you.
Who got you on line? Okay. No?
Ladies and gentlemen, please take your seat. Next session is going to start.
Hi, 李教授。
Hello.
Hi.
Hi. Good evening, everybody.
Good evening, Professor Lee. Wang教授。John Dixon.
Good evening, everyone.
Yang Hua.
Everyone. Hi, CC.
Hi. I'm there. Jiang, are you okay? Oh, good. Okay.
Professor Lee's session
Yes.
can start now. Please.
Okay. Good evening, everybody. Welcome back. So I'm Wei Jie from Taiwan. I'm happy to chair this section about the important topic, COVID-19 and bariatric surgery and metabolic surgery. And I'm happy to with the Xixi Wang. He will be a panelist and give a comment later. Today, we have 4 speakers from this region. And the first topic is how to resume surgery. It will present by Ali. Ali is a senior consultant at the Austin Hospital, Melbourne. And he's a past president of Austrian Society. And he is an expert in upper GI field. Then the next topic was COVID-19 and obesity, will be presented by Yang Hua. And Hua Yang is a young surgeon. He is the president-elect of the Ifso Young Surgeon Committee. And now he is a specialist in Guangzhou, China, and the first affiliated hospital of Jinan University. He has many creative merger pattern in his hand. Then the third topic is a new normal in bariatric and metabolic surgery from surgical aspect. Will be presented by Xixi Huang. And CK is from Taiwan, and he currently is superintendent of the metabolic surgery center in Chinese University, Taichung, Taiwan. He is a creative surgeon. He performed the first sales Roux-en-Y bypass and innovated the gastric banding procedure and performed a lot of new procedure. And he is the founding chairman of the ICE. Then the last topic was the new normal in bariatric and metabolic surgery, integrate health aspect. Will be presented by Professor John Dixon. John Dixon is a head of clinical obesity research at Baker Heart and Diabetes Institute, Melbourne, Australia. I think he's a well-known research in obesity field and published a lot of paper. And so today we have a very strong speaker to talk about this important disease. And it is the reason why we need to do this virtual congress. So we will start a presentation. Thank you.
Hello and welcome everyone, and thank you to the organising committee for asking me to be involved in this Ifso Apc program. Certainly missing all my APC friends and wish we could be meeting face to face, but unfortunately that's not the case. But it is good to have this virtual program, and I've been asked to speak on recommencing bariatric surgery under the cloud of COVID-19 and what all of that means. As we've been asked, by way of background, I'm showing here my experience in bariatric surgery over the last 15 years, and you can see it covers a wide range of surgery, including complex revisional surgery. You'll see the gastric banding forms 30% of my overall practice, but when you look really at the last even 5 years, you'll see the gastric banding has fallen right away, as it has in many places of the world, and now my practice is largely resectional surgery with sleeve gastrectomy and gastric bypass, as well as ongoing revisional surgery. You see the gastric banding has fallen right away, as it has in many places of the world. COVID is highly contagious. It has a high death rate. It spreads in epidemic proportions. We've seen this all around the world, and many, many people have suffered from this. It has the capacity to overwhelm our hospitals and our health resources. And indeed, in patients undergoing surgery who contract coronavirus, the mortality is very high. So we are really dealing with a true crisis. This is a true crisis of worldwide proportions that we have not faced in our lifetime. So should we even be thinking about bariatric surgery? Is that appropriate? And if so, why? Well, the fact is, obesity is still here. The comorbidities of obesity are still with us, and they still threaten lives. More than that, obesity is a risk factor for mortality in COVID disease. And as we've seen, we're already now in a second wave internationally. We don't know how long COVID will be with us, but it's likely to be with us for some time. So we can't ignore our other health problems. We need a plan on when and how to resume bariatric surgery. Our IFSO leaders have addressed this with this paper published earlier this year as a way of beginning this discussion. And I'll be referring to that paper from time to time. But I think there are three essential considerations when we are thinking about this topic. The first is, what do we need to have in place to actually conduct surgery safely? The second thing is about patient selection. In this climate, who is appropriate to be operated on? And thirdly, as things progress, what is our timing? When should we commence surgery? How should we develop surgery after that? Should we widen the indications and so on? When COVID threatens, two things happen. One, it spreads rapidly and it completely overwhelms our hospital and our hospital system. It occupies all of our beds and our ICU beds, as we've seen tragically in many parts of Europe, not the least of which is Italy, and now we're seeing that second wave in the USA occupying nearly 80% of ICU beds. Or if there is forewarning, then we need to shut down in preparation. We need system redesign. We need to preserve our resources and be ready in case the numbers increase. So the first thing we need in place before we can even consider surgery is that we have sufficient resources available. Do we have enough hospital beds to be conducting elective surgery or even emergency surgery? Do we have the ICU beds to manage our bariatric patients? Do we have enough theatres and appropriately pressured theatres? Early on, PPE demand was very high. We need to conserve that in order to deal with our patients. So do we have enough material, PPE materials, to be able to conduct surgery safely? And secondly, what about the health infection in healthcare workers? If we don't have enough staff, then we can't conduct surgery safely. So all of these things need to be in place before we can begin meaningful discussion. We also need to have redesigned our systems to cope with COVID. We need COVID safe practices to be well established, well enshrined, and everybody educated with PPE. We need systems of testing patients and swabbing patients to clear them safe for surgery. We need specialised equipment, including closed circuit smoke evacuation. We need to establish protocols of open airway management and theatre clearance. We need to think about separating COVID theatres and elective theatres, and even splitting surgical teams so that there is reduced exposure and we don't take out a whole team if one member is exposed to COVID. So these, I think, are the basic requirements before we even discuss who we should be operating on. And this is going to be the most contentious area, of course. Who should be offered surgery in the context of COVID limitations? Well, I want to introduce this phrase of high value, low risk. Whenever you're in a situation where there is high demand on resources, what you want to be able to do is deliver high value. You want to get your treatment to the patients who are most likely to benefit or need it most. They are our high value patients. But on the other hand, in this climate, we want to deliver low risk patients. We don't want to have excessive morbidity or mortality. We don't want to be occupying our beds, and we certainly don't want to be using up our ICU resources. So we need to get this balance point between high value and low risk patients. The problem in bariatrics, of course, is very often the patients that we perceive in most need of urgent surgery are the ones that have severe comorbidities. So whilst they might stand to benefit, the problem is they're also higher risk to operate on. So how do we get this balance? Well, in that IFSO paper I referred to earlier, there were two categories of patients that were discussed. The first is patients that have complications of previous bariatric surgery that are causing significant symptoms. The second is more elective, those patients that may have controlled comorbidities who deteriorate over time. And the Ifso paper suggests that these are two groups in whom it would be reasonable to consider bariatric surgery. But I think we need to look at this in a little bit more detail. We can break this down a little bit. Let's look at the emergency surgery patients first. So if we take the statement, patients with complications of previous bariatric surgery causing significant symptoms, I think we need to define significant. And what I would put is clearly the emergencies: leak, sepsis, obstruction. These patients need to be dealt with. They have a life-threatening condition. Dysphagia is a side effect, and malabsorption is a side effect. But if it's compromising nutrition, okay, now it's starting to get dangerous. This is the time to intervene. But simple dysphagia, not compromising nutrition, that can wait. Or disabling reflux or risk of aspiration. So I think we need to assess the side effects and determine what threat they are having to that patient's immediate life. And it all has to be in the context where non-operative management is insufficient to deal with their problems. I guess greater context is around elective surgery. So patients with controlled comorbidities who may deteriorate over time. But I think we need to be able to be objective about this, mainly because we are not the only ones deciding whether bariatric surgery occurs or not. There's hospital administrators, there's policymakers, and obesity has stigma. So we need to be able to justify what we're suggesting. And I think we can be objective. And one of the tools that I think is very useful, this is something that we've adopted, is to use the Edmonton Obesity Staging System. This classifies a mortality risk to a patient, which allows you to be objective and to justify surgery on the basis of mortality risk. So the Edmonton staging system, we don't have time to go through all of it, but basically patients are scored 0 to 4. Either they have very, very little mortality risk, or they have subclinical disease, which confers a small mortality risk, or established disease like diabetes, so or end organ disease or end stage disease. And if you use this classification, it better stratifies patients into mortality risk. If you look at the graph on the left, you see the mortality separates according to Edmonton score, but it doesn't always separate well simply by BMI. So by staging the obesity, we have a better estimate of mortality risk. And what I'm suggesting is that patients who are Edmonton 0 have very little mortality risk. We would not offer surgery because they've got plenty of time on their side. They can wait. Similarly, end stage patients, they have a very high mortality risk. Very high mortality risk and not justified to be operated on in this kind of environment. Patients with subclinical disease can also wait. So we're really looking at Edmonton score patients of 2 or 3 have established disease or established end organ disease who we could consider for surgery in this restricted climate. The important thing is we know that if we choose Edmonton score 2 or 3, we know we are saving lives because they are at mortality risk. We know we are providing for those who are most likely to benefit, and we can easily justify this decision to. The other side of the question, though, is can we do these patients, Edmonton score 2 and 3, with acceptable risk? That is, without the need for ICU, short stay in hospital, and minimum complications. Well, it's harder to get data on this, but we have some data here at our own hospital, at the Austin Hospital, where we use this Edmonton score for eligibility criteria. And so if we look at our selection criteria, VOSS2, with a BMI less than 50, and we only do primary surgery, but we do include bypass in that, in actual fact, our need for ICU was 0. Our transfer to HDU was very small. And the need for intervention, re-intervention after the original surgery was less than 1% during that hospital stay. And the median stay was very short. So in fact, we can, if we use these criteria, BMI less than 50, primary surgery, Edmonton score 2 and 3, we can deliver, I believe, high value, low risk and low ICU demand bariatric surgery for this COVID restricted environment. There are probably some COVID specific adjustments we should make. Okay, COVID death increases with age and with pulmonary disease. And so the Ifso paper adds to this age of 20 to 50, only just young patients, non-smokers, no pulmonary disease, OSA, COPD, or emphysema. And I think this makes very good sense, but I would also add to this patients who have immunosuppression, either immunosuppressant drugs or conditions of immunosuppression. These patients would be at higher risk. I think we should avoid that. How do we get our timing? Well, I think when we are on the up curve of the infection rate, it's really about getting all of our systems in place. We don't have time or capacity for surgery at that time, and we're putting patients at risk. When we get to the peak of our infection rate, a very high infection rate, or hospital resources are overwhelmed, we should only be operating in life-threatening complications, emergency surgery only. But as we start coming down the curve, we can look at Edmonton Score 2 patients. As things settle and we can do more surgery, then we introduce Edmonton Score 3. And as we go back towards normal, we can expand our indications further. So in summary, I'd say in this COVID-restricted environment, we want to choose young patients, 18 to 50. BMI less than 50. Primary surgery only. In our case, insured patients only, not self-paying patients because of the financial risks. No immunosuppression, non-smokers, no pulmonary disease, and demonstrable Edmonton score of 2 or 3, which helps us justify it based on mortality risk from their obesity. No more than 2 stable metabolic comorbidities. We don't want to expand that risk greater than that. And we emphasize where conservative weight loss management, even temporarily, is not possible for that patient. And we can expand our activity strategically according to the prioritization criteria that we have in place. And with that, I'll end, say thank you, and I hope to see all of you soon. Thank you.
Good day, everyone. This is Hua Yang from China. Before I start, I would like to thank the organizing committee to give me an opportunity to share the topic COVID-19 and obesity. And this is the case disclosure from our center. And while we are talking, the number of confirmed cases are still increasing. This is the real-time data I call from the internet. As we can see, and a lot of areas around the globe is still suffering from COVID-19. And from the graph, we can still see the number of cases of COVID-19 is increasing. And this is obesity global epidemiology. As we published from Nature Reviews, we can see from the graph a lot of countries from Asia, they got quite a lot of obesity. For example, New Zealand, Australia, China, Indonesia, Korea, India, and Japan. And so what happens when these two pandemics meet? And this paper was from Nature Reviews Endocrinology, and we can see that obesity contributed to a lot of respiratory dysfunctions. For example, impaired respiratory mechanism, increased airway resistance, impaired gas exchange, etc. It also causes cardiovascular diseases, type 2 diabetes, and renal function disorders, and also cause a lot of metabolic risks such as hypertension, prediabetes, insulin resistance, and so on. All these results in severe cause of COVID-19. And this paper was published by the Endocrine Society, and it shows that obesity causes a hyperactive immune system response to COVID-19 infection, and it makes it quite difficult to fight off the virus. So obesity alter the immune system response to COVID-19. And this paper from Diabetes Care, the data was from in a hospital from China. We can see from the table, if the BMI of the patient is over 28, it is a higher chance of or higher risk to get severe COVID-19, especially in male patients. If the male patients got BMI over 28, it is 5.66 times higher risk to get severe COVID-19. But it is a little bit better in women. It is only 0.7 in the OR value. This paper from the Lancet Diabetes and Endocrinology, and we can see the prevalence of obesity in patients with severe COVID-19 compared with the general population. And from the graph, we can see the general population, the prevalence ratio of obesity is low, only 1.0. And for those patients with severe COVID-19, especially those with critical COVID-19 in ICU, it is very high as much as 2.88 times higher than the general population. And this paper from the New England Journal of Medicine, it shows the social determinants of health. For example, the racial and ethical discrimination, access to health food, to health care, and the location and physical environment, social economic status, education, social and community context, etc. All these contribute to obesity and diabetes, hypertension, cardiovascular diseases. All these chronic diseases, they result in superior outcomes from COVID-19. All these are quite related to the nutrition issues and obesity. And talking about the nutrition, we should talk about the food insecurity during the pandemic. And this paper from Nutrients shows a lot of people, a lot of family, they buy a lot of food, as many as 2 weeks food for the household. And the food security insecurity is associated with the increased risk for metabolic disorders, for example, obesity, type 2 diabetes, hypertension, etc. And as we all know, metabolic disorders are the risk factors for COVID-19. So food insecurity may increase the risk of worse COVID-19 outcomes. This paper is talking about the obesity and the mortality of COVID-19. As we can see from the meta-analysis, the BMI over 25, there is a higher risk of mortality from COVID-19 infection. And this is why a lot of mass media, for example, the New York Times and Wall Street Journal, they are urged for bariatric surgery. They are talking about patients were seeking surgery to combat the major COVID-19 risk factor, that is the obesity. And the Ifso published recommendations for metabolic and bariatric surgery during the COVID-19 pandemic, and it mentions the importance of weight loss to obesity during the pandemic, and we should also pay much more attention to people with obesity during the COVID-19 pandemic. The CSMBS also published the Chinese recommendations to the local surgeons during the pandemic. And so far, the good news is that there's a interim results shows COVID-19 vaccine candidate was more than 19% effective. So we are looking forward to seeing the vaccine to the market. And but at the meantime, for now, what we can do is to keep fit. I got these posters from the Australasian College of Sport and Exercises physicians, and they initiated a campaign called COVID-19. And the main goal of this campaign is to encourage people to get more physical exercises, no matter indoor or outdoor exercises, to prevent from chronic diseases during the pandemic. And that is to keep ourselves healthy and keep ourselves prevent from chronic diseases like type 2 diabetes, heart diseases, cancer, and dementia, etc. So this is the take-home message. So for this presentation, obesity is closely correlated to COVID-19, and we need to keep health lifestyle during the pandemic. and we need to look for the weight loss interventions, no matter it is surgical one or non-surgical ones. And the most important is to wear a mask. So this is the end of my presentation, and I would like to thank for my two mentors, Professor C.C. Wang from Junior University and Professor Amy Xu from the University of Hong Kong for their support for so many years. And I would like to also thank Dr. Shirley Liu and Dr. Simon Wong for their help when my wife was giving birth to our baby girl Mia in Hong Kong in their hospital during the COVID-19 pandemic. And finally, of course, I would like to give a big thanks to my wife, as always, for everything. So 2020 is a tough year, but it is also a new start. Thank you very much for your kind attention. Thank you.
Hi, this is CK Huang from Taiwan. Nice to receive the invitation from the Ifso Apc. I was assigned a topic about the new normal in bariatric and metabolic surgery, surgical aspects. Love to meet you in the air. My case mixed disclosure is my main procedures for bariatric surgery is sleeve gastrectomy, and Roux-en-Y gastric bypass is the second one. The other is sleeve with loop DJB or proximal jejunal bypass. Today, my outline is about the Taiwan COVID-19 condition and how about the elective bariatric and metabolic surgery and treatment in our center. In severe pandemic area, what's the recommendation and my conclusion? The worldwide COVID-19 now has affected 58 million people, and over 1 million people die from this COVID-19 pandemic. So totally affect 191 countries in the world. So it's very bad condition right now. So since this April, Ifso have given the recommendation about bariatric and metabolic surgery during this pandemic. In fact, recommend is no any elective bariatric and metabolic surgery, including treatment. The general recommendation is should be postponed during the pandemic to minimize the risk to both patients and the healthcare teams, as well as reducing the utilization of unnecessary resources such as the ICU beds, the ventilator, and PPE use. In addition, to postpone this service could minimize the potential exposure of the COVID-19 virus to unsuspecting healthcare provider and patients. So try to protect us and protect the patient in this kind of very severe condition. We should postpone the surgery. But otherwise, the Taiwan government and all medical surgical society do not set any limitation for running clinic, endoscopic procedure, and elective and laparoscopic surgery till now. The reason is because in Taiwan, the COVID-19 is very well controlled. Till now, there's only 618 cases was confirmed to get infection of COVID-19, and 7 persons died from these COVID-19s. So you can see in the figures since the end of April, almost the case is very sporadic, and most is come abroad, not the community spreading cases. So I try to summarize our patients' data to compare with 1 year ago, since the January to October. You will see all the cases coming for the surgery. In fact, we still have very standard flow chart and protocol for them. For all the patients come to the hospitals for appointment and plan for surgeries, we have the preoperative screening for that. If the patient was suspected to have the COVID-19, we send to the ER isolation tents and for further checkup. Those who pass the protocols, then they are clear, can go for operation. So the indication and patient selection was done accordingly. Then we do all routine checkup, and including gastroendoscope and echo and X-ray. And we did not routinely use the chest CT scan unless we have some suspected findings. So from the last year to compare with this year, you will see, in fact, in this period, there's not much difference compared with last year. Even the cases we done is even higher than the last year. But in the other area, those with severe COVID-19 pandemic area, in fact, mostly the society will postpone the bariatric metabolic surgery because of infection risk among the patient and staffs, and the factors inherent to the operations, and also increase the hazards of severe COVID-19 complications for those who suffer from the severe obesity or type 2 diabetes. And also the laparoscopic surgery and endoscopic procedures, in fact, involves aerosol generating techniques, so can cause more contamination of viral spreading. And in fact, how we can manage these kind of conditions, whether we should not do anything for them. So the DSS recommendation this year published about 3 kinds of access. I think we can put this into our consideration. Number 1 is urgent access. The surgery should be done within 13 days. Those patients' conditions associated with more severe deteriorating conditions and with severe symptoms or dysfunction. So when you have some this kind of cases, the patient need to having surgery in 30 days. You still going on for surgeries. Some patients should be done with within 90 days. It's called expedited access. The patient condition not likely to deteriorate quickly, but there's a substantial risk of morbidity or mortality. And there is some reasonable risk of harm. And if the surgery was delayed beyond 90 days, there is some reduced efficacies. So in these kind of conditions, you still can do the surgery within 90 days. For the green light, it's a standard access. In fact, we should postpone the surgery after 3 months later. The patient's condition are unlikely to deteriorate within 6 months. The patient have only very mild dysfunction or symptoms. The delaying surgical treatment beyond 90 days will not cause the reduce the effectiveness of the surgery. So in fact, DSS set the standard for the bariatric surgery and also for the diabetic surgery and also adjuvant bariatric and metabolic surgery. I think you can put this reference for yourself. Some cases standard access, some is expected access. So you can put as your standard protocols. So when we have, if we someday passing through the COVID-19, how we are going to restart the elective surgery, I think this was published this year by most of our Ifso members. For those who is in the criteria of bariatric metabolic treatment and surgeries, we recommend that you should have an RT-PCR test first. If it's negative, then you can get the surgical consent. For those who the patients having the surgeries, in fact, after surgery, the patient still need to go for self-quarantines for 14 days. So pre-op, including the preparation and consent form to the patient, and also the OR setting need to be negative pressure OR systems, and use smoke evacuators, and also use a bipolar device, avoid two-way valve-free insufflators. And for personals, of course, to decrease the number of the staff, and also follow the PPE protocols for contact. And also discharge the patient about 2 to 3 days later, but the patient need to resend the PCR test before discharging, and also self-quarantine for 14 days. I think this is the recommendations for those who underwent the bariatric surgery. So after the COVID-19 pandemic go on. So what are we awaiting now? In fact, I think we can only wait is about the vaccine. Now there's been a few vaccine has been coming out, but I think almost including the WHO did not give the exact date when the COVID-19 vaccine can be spreading to the whole world. So I think maybe still 1 year we need to wait for everything going down. So my conclusion is elective bariatric and metabolic treatment do not need to be postponed in no community transmission area like Taiwan, but you must include the proper screening and protection measures, and also have the standard protocol and executive pathways. I think a new normal still waiting for the vaccine to arrive. Right now, we have to set priority for the patient and also follow the standard checkup and recovery protocols before the earth becomes normal. Thank you very much for the invitation. This is my talk.
Good evening from Down Under. It's a great pleasure to be joining you for this virtual conference. Today I'm going to talk about bariatric metabolic surgery, the new normal following aspects of COVID. And I'm going to focus on unleashing the power of people, how digital services can transform health. I'm going to use a very positive approach to this. There are my disclosures. I work in the obesity world, so I'm conflicted with surgical companies, drug companies, and nutritional companies. So what's telehealth? Telehealth is the tool you've all been using very much recently. It's there to enhance healthcare, public health, improve healthcare, education, delivery, support, and support communication and information. We've all got used to using this for our conferences. We've got used to using this for our meetings and so forth during this COVID period. When it comes to healthcare, though, we're behind. The healthcare industry is generally behind in quality digital platforms. And what we see here is that telehealth, artificial intelligence-enabled medical devices, blockchain, electronic health records, etc., are there to transform health. And we really haven't grabbed this adequately. COVID-19 has presented us with immediate challenges that have accelerated the need for embracing telehealth opportunities. Given the increased aging in our communities and chronic disease in our communities, and as you know, obesity is very much part of this, we need to be able to improve our workflows, improve patient outcomes, reduce human error, and deliver efficiencies in presenting, in treating chronic disease. Of course, there's always resistance to change. When we look at the internet, we're seeing the initiatives from globally, from physiotherapists, for exercise physiologists, from dietitians, psychologists, all grasping the ability to communicate with their patients at this COVID time. And most importantly, the ability to coordinate chronic disease management. When we look at the wearable consumable, the consumer wearables, we all know about the Apple Watch that I have here. We know about other things, headbands, cameras, etc., etc. All in a position that we can use, providing the patient with details, providing medical practitioners and allied health people with data that can be used to assist in self-diagnosis, assist in behavioural change, etc. But of course, there's concerns with security, reliability, etc. Good examples of these are fall detection, which is available on some of the watches. Sleep, we can look at the time of sleep, the quality of sleep, and with a pulse oximeter, actually measure the oxygen tension. When we look at heart disease, we can also detect and have these instruments designed to detect serious or potentially serious arrhythmias, such as atrial fibrillation. So when we look at our COVID experience, most of us have been struck by the fact that we have to now do virtual consultations. And that's something that's important, because seeing the patient in various places at different times is quite time consuming. So COVID-19 has made a significant impact on chronic disease management, particularly people living with obesity. It's changed our practices dramatically, and we are now having to adopt virtual clinics or virtual management of patients. When we look at chronic disease management, which is really a crisis in care broadly that was coming upon us, we have the health systems delivering, and we have community resources, and we have this interaction between our practice and the patient. And the critical thing we need to do is to be able to deliver the right thing to the right patient at the right time. And that means bringing all of those allied health and medical interventions to the patient at an appropriate time. When we look at how we manage chronic health conditions, we actually typically use a very piecemeal approach. To bring things together, we need community mobilization, and obesity really fits this well. We need to empower patients with self-management support. We need health systems that can integrate with one another and enables you to communicate with other allied health and health professionals, deliver transformations in ways to meet, collaborate, and care for our patients. It's got to be evidence-based, and we need information systems that are smart and can actually interact with one another. You and the rest of your team and the patient being able to be discussed at once. So we have a great opportunity to do this. There are problems with virtual consultations. I'm sure you've expanded this. You know, is it just over the phone? Videos certainly enhance things a lot. How do we get essential biometric information? We're learning how to do that. And of course, the ability to examine the patient is very difficult. In fact, impossible, and we should be quite precious about that at times. Communication resources are important. We need electronic medical records that can be accessed and changed off-site using a blockchain method of security. We need to know how to order and receive pathology off-site. We need to have the ability to refer between one another off-site, deliver for doctors, delivering the pharmacotherapy and alternative delivery methods to the patients. And of course, we need billing and those sort of things done. Overall, we need absolute security and integrity of the system so that we can work happily as a team that provides this. Now, when we look at bariatric medicine, which I always include bariatric surgery as part of bariatric medicine, we have an opportunity to bring this together, and it's not really done very well previously. This is, you know, just we're recognizing obesity as a disease. We've recognized it's a disease for a long time, but we're now recognizing seriously as a disease. We not only have all the teams that are associated with bariatric metabolic surgery in our team, but we have to have all these outside services that integrate with us. And it's really important to see that a team does need to be organized, and we need to make sure that we're using those opportunities to treat our patients better. Human resources in developing a team are important. Our patients are very stressed. These are patients in Australia, those with severe obesity, with diabetes, often have poor education, disability, poor employment, poor educational opportunities, etc., etc. Everything's loaded against them. And we have to be sure that when we use these integrative programs that we're developing, we need to think about the patients and their distance, the distance from us. Health literacy, appropriate digital platforms, socioeconomic status, cultural and language appropriate interventions and discussions, consider their mental health. And the tools that we use to assess and screen patients, we also need to be able to engage with them and deliver interventions and provide ongoing support. We do need in these methods to be able to develop quality behavioural programs. High functioning teams are transdisciplinary teams, teams where we get together, where as this is the bottom one here, members are jointly responsible for implementing an integrated plan for the patient with a serious condition, such as clinically severe obesity. A team working together with the same goals to get a better outcome. Transdisciplinary approaches are really vital when trying to solve major problems. And if we look at, you know, how we get the skills together to improve our environment, build better cities, make better products, prevent obesity and diabetes, and do the sort of work we do in chronic disease, we need to be able to communicate. Each of us has our own skill set, and we're trained in different ways. We have different cultures, different biases. We need to be able to use telehealth and electronic medical records and emerging disciplinary practice to bring those opportunities together for us to communicate with one another and us to be able to communicate with our patients. There's a great interest in, we have a lot of one-to-one communications. This is about one-to-many communications. A psychologist dealing with a number of patients at the same time, a physician dealing with a number at the same time. It's efficient, and the problems that these people with chronic disease have are often very similar. Of course, this doesn't take over from the one-on-one consultations and chats that have to happen, but efficiency often demands that we start to use one-to-many. And of course, we can do that over the telehealth methods. We can also do that with one another. We can have our team meeting in different places so that we can come together and discuss individual cases. So in summary, the COVID-19 pandemic has presented challenges and opportunities. COVID-19 will have a lasting effect on healthcare delivery, and to move to more efficient digital platforms will be enormously beneficial. I urge you to embrace this change and recognise the strengths and opportunities that it can deliver. But there will be weaknesses and threats. We already know that there's a lack of, we have the problems of face-to-face conversations, physical examinations, assessments, investigations, interventions, etc. Cancer presentations have reduced. Cancer screening presentations have reduced. People are presenting with more advanced cancers. So we have some problems there. We also, if we introduce technology, we have to think about those that may be disenfranchised, those often at greatest risk. And of course, security for our information is vital. Thank you. You're asleep.
Okay. Good afternoon. It's been almost 1 year since the outbreak of COVID-19. At the beginning, we did not expect that it will affect our daily life and work so much. Now, in different countries, the epidemic situation is still not completely under control, and there is still the possibility of the second and the third wave outbreak. However, we have seen the back of victory. The prevention technology is gradually improved, and the COVID-19 vaccine has been gradually used. I believe that we are not far from the day when coronavirus will be completely overcome. come. So in Manantiala, bariatric surgery decreased significantly in the first half of this year. In the second half of this year, the epidemic situation was basically under control. Bariatric surgery was gradually resumed, and the number of operations was gradually increased. And obese people have more time to learn about bariatric surgery through the internet during the epidemic. The amount of bariatric surgery in some hospitals has obviously exceeded the amount of surgery than last year. And in all hospitals, the number of bariatric surgery cases has also obviously exceeded the number of last year. So I have several questions. First question is for Sekhwan. Sekhwan, good afternoon. Has your hospital resumed routine metabolic and bariatric surgery?
Open your mic. Yeah, we don't hear you. Hello?
CK, I think you are muted.
Okay. Or maybe we can do the poll first. We have 2 questions for all the audience. Maybe we can do this. Manuela? Yes. So we have 2 interesting questions for all the audience, and we can see what is the response. So please select the answer. Has your hospital resumed routine metabolic and bariatric surgery? The first is yes, fully resumed. The second is certain extent. Then the third is not really at all. So please select. And we can see the inference in this region. We will have 6 seconds for all the questions. Yes, so as my expected, 50% has fully resumed, yes, and 35 is certainly, and only 16% is not really at all. So I think the COVID-19 is better controlled in this region comparing to United States and Europe. I think all because we have the experience of SARS. So I'm glad to see 75% our colleagues can start to do some bariatric surgery, and 50% already have full recovery back. So let's see the next question. How is the number of cases of bariatric surgery affected by the COVID-19 pandemic? You can choose the answer. The first is number of cases increased. That must be very rare, I think. Number of cases decreased this year. And the third is more or less the same. Please answer your answer. Oh, so yes, most of the centers are affected by the COVID-19. Yes, but still some increase, 16%, and the same is 13%. So this is, I think, the general aspect of APE. So thank you, Manuela, for the poll, and we back to discussion. So we now have CCK back. So Would you like to answer? Yes. Okay.
Yes. In Taiwan, in fact, the condition is quite well controlled since beginning. So in fact, we did not have any problem in doing the elective bariatric and metabolic surgery till now. So I think Taiwan volume might be similar compared with last year.
Good. Okay, good.
Thank you.
Yes, please, Shishi.
Okay. This a question is the paper from Qualified Clinical Bariatric Surgery lessen the severity of SARS-CoV-2 infection. What is the opinion of this paper? According to the paper, is bariatric surgery recommended for special patients during the pandemic? Lessen the risk?
Any comment from the panelist? I think this paper is just published by Cleveland. They compare the patient with previous bariatric surgery comparing to the same obese patient with COVID, and they find 2% mortality in the obese population, but non-mortality or ICU admission in the previous bariatric surgical patient, and support the benefit of bariatric surgery for obese patients to counteract the COVID-19. So,
okay.
Yes. Do you want to give some?
I might
okay.
say, I think the quality of this evidence is very low. This is simply looking at two groups. We have no idea that the numbers are low. I think to take on at-risk patients at a time when you've got community spread and a lot of risks for not just the patient, but for the healthcare workers, etc., is rather irresponsible. And we're thinking about the person who has the surgery and just might get COVID-19 in the future. That's generally in many of our communities, particularly in the Asia Pacific, is actually quite low. And we hope to have a vaccine next year. So I think, as has been discussed already, a very cautious approach to operating on those in most need for other reasons, but not with the view to saying, well, they'll be better off if they catch this disease. Let's prevent the disease in these people.
Okay. One more question. Do obese patients who don't have bariatric surgery during COVID-19 become more obese while quarantined at home, or will they lost some weight? This question for Ahmed Ali. Thank you.
Yeah, thanks, CC. We certainly in Melbourne and in our practice and around Australia, when we were talking to other surgeons, we definitely saw this. You know, we saw it in patients who have not had surgery, that they found it harder and harder to control their weight. And they became more and more desperate for surgery, especially when the surgery was cancelled. And the patients that already had surgery, they found it more and more difficult to keep their weight loss going. And they started to panic because they're at home in quarantine with food, they're not moving, they don't have the usual support. But we found many of them ringing our clinic all of the time. And we had to make new ways of supporting them. So, you know, our dietitians designed new education programs and new motivation programs for them specifically during quarantine. Even our dietitians, sometimes they did, you know, like webinar like this, Zoom conference with the patient in their house, and they went to the pantry to look at the food and talk about which foods they're using and which foods they're not using. So like John said, there was some opportunity to actually deliver support and treatment in a new way. But many, many patients struggle. You know, we have this expression with COVID, we say we want to flatten the curve. We want to bring the infection down. We want to flatten it. But sometimes for our patients, they were fattening the curve. Because the fridge, they were getting bigger and bigger and bigger. So yeah, it was a problem.
Okay, that's answer. GK.
Can I give one comment? In fact, even no quarantine, no COVID-19, the patient don't receive bariatric surgery after clinic visit, they come back with more weight, always. So I think quarantine is not the problem only. In fact, those morbid obese patients always become heavier and heavier if they receive surgery. That's my comment.
I think this is a two-edged sword because not everyone was unable to exercise, and some people really had time on their hands to do that. The other thing is that we had a decrease in the use of fast foods and eating out at expensive restaurants and really glorifying food. We had an opportunity for people to cook more and learn to cook at home. There were a lot of things happening, and unfortunately, when we looked at a lot of what the press would say about the COVID-19 environment, it was very depressing and very worrying. But there were opportunities, and Ahmed has just told us about his dietitians and how they empowered. We saw our exercise physiologists ringing people up. Right, they couldn't meet them anymore, but they'd ring them up and they'd give them support and so forth. So I think these are opportunities, and I don't know yet as to whether the general population put on weight or not, or whether it would be different in different environments. Certainly, I've been out of Melbourne. Ahmed's been in Melbourne. I've been in an environment where I've never exercised as much in my life over this last 6 years. And I haven't lost any weight. I haven't put any on, but we've noticed that, and it's the way you sometimes play, you know, a catastrophe is that everything must get worse, and we saw that that hint with some of the situations such as suicides in Australia. They were meant to get worse. They reduced. So there was a problem there, and yet there's a lot of anxiety and depression. So not everything has to go bad.
Okay, Ali.
Yeah, sorry, John, I think you're right. There is that two-edged sword, but I was reflecting on what our experience was with patients calling us. And the other part of it was many patients, and I'm talking about our bariatric surgery patients now, the ones that already had surgery, who are doing very well. But the pandemic was stressful for everybody. I mean, maybe suicide didn't go up, that's fine. But our patients were getting more and more mentally stressed. That led to a little bit more emotional eating. The quarantine, yes, they did exercise, but only 1 hour a day, because that's what they were allowed to go out and walk, but then they got stressed. So yeah, it's going to affect people in different ways. My impression certainly was our patients did struggle and they needed extra support from the clinic.
And I think the other aspect was that obese people became more stigmatized. They were the people who were going to get this disease. These are the people who were and it was really quite difficult to not worry them and to really reassure them that you know, they can continue doing what they're doing and receive help without feeling more pressure. And there was a lot of misinformation around, sadly. So we've got to reduce stigma and empower our patients rather than always think whatever happens, they'll be worse off. And they feel that, and they really felt that, many of them.
Okay. guys, we are running out of time, so I think the last comment for Yanghua.
Oh, and yeah, I just
Yeah.
want to share a experience from my friend. I read that post from Facebook, and his situation is totally different. Before the pandemic, he got a lot of work to do and don't even have chance to do don't have the chance to have physical exercises. But during the pandemic, he has more time to stay at home, so he listened to the doctors. He gets some physical exercises at home. Actually, he lost some weight.
So that's really depends on your lifestyle and motivation and something, yes.
Yeah, and also with some paper, they mention about a healthy lifestyle medication, and they in mainland China, some physicians try to promote these concepts. Yeah.
So I think thank you everybody for joining this section, and I think we have a great achievement, and thanks all the attendants. I hope you like this section. So we close this section at here. Thank you very much for your participation. See you soon.
Thank you.
Thank you.
Bye.
Bye. 我要关掉了。
Ladies and gentlemen, next session is going to start. Please take your seat.
Can't hear you, Simon. Guys, can you hear?
Yep. Simon can't hear you.
Simon, are you unmuted? But I can't hear you. Neither can Ken, neither can Mass. You can't hear us? Okay, but we can't hear you. There's a problem. Okay.
We still can start, I guess. It's the end of the session, hey?
Yeah.
Well, I guess, you know, I don't look like Simon. Simon is more handsome than me. So, you know, I think so as a team as well. But I think the sessions now, we're trying to.
Okay, can you hear me?
Ah, it's good. Simon, back on board.
Okay, now they allow me to speak. I don't know. But anyway, welcome all to this section. The bariatric endoscopy is Asia ready. So I have my honor to have two panelists, Dr. Asim Sabay from Singapore, and also Ken Loy from Australia, two Asia and non-surgeon to be the panel here. So today we have two sections, two topics. The first one will be by Dr. Mohit Benedette, and he will talk about the criteria on selection and protocol of primary endoscopic procedure. And then we will follow by Professor Matthew Cole from Kipling, and he will talk on endoscopic intervention for complication on bariatric surgery. And I hope you all can enjoy the talk, and we will come back after the talk and discuss more and have some poll on this topic. So thank you, everybody. So we can start.
I am Dr. Mohit Bhandari. I am founder, director and chief surgeon at Mohawk Bariatric and Robotic Surgery Center, and it is my honor to speak on the Ifso Apc on the criterion for selection of procedure for primary endoscopy. So I bring greetings from India. This is our center where we perform bariatric and metabolic surgery. These are my disclosures. I am an advisor to Apollo Endosurgery, and I leave it to your wisdom to decide in the light of my disclosures about my lecture. We performed all kind of procedures at Indore at Mohawk Bariatric and Robotic Surgery Center, and we do perform endoscopic sleeves, and we have experience of over 200 cases of endoscopic sleeves at our center. Along with that, we do perform several other procedures at our center. I have been asked to speak upon when we should perform endoscopic sleeve gastroplasties. We all understand that diets, exercise, behavior modification, psychological counseling, and pharmacotherapy have very poor outcomes as far as morbidly obese or even overweight individuals are concerned, and there is a high attrition rate. Surgery is the only viable option. But the problem is that do we have something to bridge the gap between the diets, exercise, the behavior modification, and the surgery? Endoscopic sleeve gastroplasty and bariatric endoscopy at large, I think is the option which is available to us. And so I would like to discuss algorithm at our center, the Mohawk Bariatric and Robotic Surgery Center, that when we perform endoscopy and when we perform bariatric surgeries, because that's the burning question, that when should you counsel a patient for bariatric surgery and when you should do the endoscopy. So we offer all the candidates above 27.5 BMI, either of two surgeries, and we do all these primary modalities like sleeve bypasses, one anastomosis, sleeve press procedures, and the ESGs. Now, at our center, any patient who has a GERD, esophagitis, or a hiatus hernia greater than 3 centimeters would never get a laparoscopic sleeve, but patients with GERD and esophagitis would tend to get a gastric bypass. Similarly, there are patients who have history of active peptic ulcer disease, anemia endemic areas, inflammatory bowel disease, would never get a gastric bypass, and because these are the patients who are a contraindications, and therefore they would tend to get a sleeve gastrectomy at our center. At the same time, there are patients who have severe GERD, esophagitis, hiatus hernia, and a history of alcohol abuse will not get a one anastomosis gastric bypass. But patients who have a very higher BMI, somebody who has very severe diabetes, somebody who probably is ready for a very frequent follow-up would get a one anastomosis or a mini gastric bypass. In short, what I wanted to say is that we have indications at Mohawk algorithm for all these procedures, but when I am asked to speak about an endoscopic sleeve gastroplasty, our indications are very clear. A patient with a BMI of more than 27.5 and less than 32.5, or patient with a BMI of more than 32.5 who does not want a laparoscopic surgery. Patients who have medical condition in whom laparoscopy surgery is contraindicated. Patients who have failed sleeves bypasses or one anastomosis who required some sort of an intervention to give them a forced compliance. And patients who are contraindications even for endoscopic interventions, like a terminal disease or uncontrollable coagulopathy, even if they are morbidly obese, would not get an endoscopic sleeve. So in nutshell, any patient with a BMI less than 32.5 but greater than 27.5, or greater than 32.5 who are contraindications to laparoscopic surgeries, or any medical condition which make them unfit for laparoscopic surgeries, gonna get an endoscopic sleeve. This is a therapeutic approach to the obesity, and we all understand that before doing a laparoscopic sleeve or a vertical band or a RYGB or a BPDDS, we need some gap from pharmaceuticals to these radical surgeries. And I think endoscopic sleeve gastroplasty, along with other bariatric endoscopic procedures, are a very good arrangement between the therapeutic approach and the surgical treatment. It is a good bridge, like a primary therapy, also for some revisional procedures where patients regain weight after bariatric surgery, and also, as I said, a bridging procedure. The advantage of this endoscopic bariatric interventions are that they are lesser invasive than the surgery, they are reversible, they are low cost, and they can be repeated for multiple number of times. Just for an instance, if I have a patient with endoscopic bariatric therapy which has regained weight, I can go inside and do another endoscopy and do another endoscopic sleeve and discharge the patient evening or next day in the morning. So the repeatability of the procedure, the freedom to escalate the procedure into bariatric surgery is so high with endoscopic sleeve that it becomes a very, very important and very, very preferred modality to bridge the gap between the therapeutic approaches which often fail and the surgical approaches which are very radical and have more complications. If we see, the endoscopy is now having a lot of impact on bariatric surgery in terms of preoperative endoscopy, post-op surveillance, and in fact primary therapy for obesity in terms of bariatric endoscopy. These are the different therapies for primary and these are the different therapies for secondary, but I would want to mention here that even revisions after bariatric surgery are better tackled by an endoscopy than the surgical revisions due to high rate of complications. We have to understand that we do not want a more than 100% excess weight loss for patients to have resolutions of their comorbidities like type 2 diabetes, hypertension, or sleep apnea. In fact, most of these studies say that just less than 5% of excess weight loss or 5 to 10% of excess weight loss is good enough to give a patient a very good control of diabetes, a very good control of his sleep apnea, arthritis, or depression. So there is a place where endoscopic sleeve plays a very important role. We should also understand that all operations, even the surgery, are just effective for 3 to 4 years, and then it is the patient compliance which comes into place which determines the long-term success of most of the bariatric procedures. This is our experience. At Mohawk Indore, we did around 143 endoscopic sleeves. I'm not taking my experience because I perform equally number of these procedures outside my center, but this is my center's experience. So these are the procedures which are done. This is our result at around 12 months, a 20% of total weight loss, which is phenomenal with endoscopic sleeves, almost in parallel with bariatric surgery. We did 42 revisions, and we revised quite a bit of sleeves, RYGBs, one anastomosis, and we did 3 re-ESGs also. As I said, there is ease of re-intervention, and our results have been phenomenal with re-sleeves or converting a sleeve into an endoscopic sleeves and then doing an outlet tightening of the gastric bypass. And this is our data reflecting 13.6% total weight loss at 12 months with revising failed sleeves, and sleeve being the most common bariatric surgery done across the world. This is a short video of how endoscopic sleeve is done. As surgeons, we know, those who have been exposed, that we are doing full thickness suturing with Apollo endosurgery device. This is a helix which is pulling the tissue, and you can see that the overstitch device is taking full thickness sutures. We go in a U-shaped pattern or a V-shaped pattern. There are different patterns available. At the end of the day, the motive is to create a very nice tube, just like a sleeve gastrectomy, which gives patients a forced compliance and a feeling of fullness after eating the food. So this is the procedure. This is the only publication from India, and the first Indian experience which we published at our center, the endoscopic sleeve gastroplasty, a safe and a minimally primary approach for the treatment of obesity, and a good amount of experience with this. I would conclude by saying that obesity is a lifelong disease, and any intervention, even surgery, provides only a remission and amelioration and not a cure. So thank you very much. This is my team. I work with Professor Phoebe as an advisor and a consultant at Mohawk Hospital. And I would like to say that we offer various treatment modalities for obesity, including the endoscopic sleeve at Mohawk. And the operation at our center at Indore is determined by the profile of the patient and guided by our findings from the analysis of our data, which is prospectively maintained and published in the literature. Thank you very much for the Ifso APC team to have invited me. Have a great day.
Hello and greetings from Abu Dhabi. I'm Matt Crow. Thanks to the organizers of Ifso APC for putting this together and for the opportunity to speak today. I only wish that I had a chance to be with you, but hopefully all of you are well, and I look forward to catching up with you soon. So my talk today is on endoscopic management of bariatric surgery complications. And I have no disclosures that are pertinent to this talk, though several disclosures. So endoscopic intervention after metabolic procedures has clear advantages. It avoids a reoperative surgical intervention and has a relatively lower morbidity than surgical reintervention, but there are disadvantages too, and that includes challenges in training and limited tool sets. But the tool sets that we have are evolving, and new technologies are entering this field rapidly, including new platforms, including devices that allow us to triangulate, retract, divide, and seal tissue similarly to laparoscopy. And currently we have instrumentation that mirrors some of the devices that we perform laparoscopically. This is an example of a triangle tip knife, an insulated tip knife, and a hook knife that we use for ESD, POEM, and POP procedures. We also have caps on the end of our endoscopes that allow for tissue retraction. And we have better suturing devices with different choices of suturing material and more robust suturing systems, as well as closure devices. So I'm going to talk about a few different topics in management of complications endoscopically and show you how they're interrelated. Strictures remain relatively common depending on the operation that were performed and techniques, and the intervention needs to be based on what operation was done, whether it's a sleeve gastrectomy where stenosis may occur or an anastomotic operation where true stricture occurs. And of course, it's important to realize that chronicity may dictate intervention and also etiology. Acute complications may result with later manifestations, and of course, there are chronic processes as well. As far as anastomotic strictures, these often can undergo endoscopic dilation. This is a fluoroscopy showing a completely occluded gastrojejunectomy. This is the endoscopic image of a small aperture anastomosis, and this often will respond well to through the scope dilation. And balloon dilation is quite successful in terms of treating early strictures, but are not without complications, including recurrence and perforation, but overall are safe and effective. However, sometimes when you perform a balloon dilation, you may end up with free intra-abdominal air such as this, as you can see under the diaphragm. Now, of course, in the setting of sepsis, this may require surgical intervention, but endoluminal interventions might work very well too. And one option that you have are esophageal stents. Esophageal stents come in many different technologies. There are plastic and metallic, fully covered, partially covered, and uncovered stents. And increasingly, new technologies include asymmetrical and over-the-wire stents as well. The data for stents for leaks is quite good, especially for acute leaks, greater than 80%, and it allows patients to resume oral diet as well. Patients do have symptoms, epigastric pain, reflux, and sometimes nausea, and migration can occur with widely variable rates depending on the type of stent that's used. So since sleeve gastrectomy is one of the most common operations performed worldwide, I think it's important for a group of surgeons to realize why leaks can occur. So in this fluoroscopic image, you can see the leak just distal to the esophagogastric junction. But the reason why this leak occurred was a near obstruction at the incisura in the mid-body of the stomach. Endoscopically, not this exact patient, but similarly, you might expect to see something like this. This is the pylorus. The scope is being withdrawn backwards. And now you can see that the incisura is quite tight here with an abrupt turn. And as we bring the scope further back, we now see suture material and fibrinous debris. And careful examination of this actually reveals a full thickness defect. Endoscopically, this is washed out. The fibrinous necrotic debris is removed, and the drain is repositioned for better drainage. This particular patient underwent luminal clipping in fibrin glue as well as a stent placement, and this is the picture of the stent after removal. So stent treatment, therapy duration will depend on the discretion of the surgeon, may require more than one stent, and remember that partially covered stents should only be placed for probably 2 to 3 weeks before they're removed. This is the fluoroscopic image of that patient showing not only resolution of the leak, but patency of the incisura. This is a different patient that shows that partially covered stents left in place for long times can have robust tissue ingrowth and can be challenging to remove. So if you're going to use partially covered stent, realize that they may be less likely to migrate, but that they will require earlier removal to prevent this tissue ingrowth. This is another example of a small leak endoscopically. This is just 1 millimeter or 2 distal to the esophagogastric junction. The patient presented with left shoulder pain and a mild leukocytosis associated with low-grade fever. A stent was placed, and this was a longer stent, stenting open the incisura as well as the GE junction. This is the fluoroscopic image. Injection shows contrast extravasation. The 2 paper clips show the pylorus and incisura respectively. You can see the contrast extravasation going up to the left upper abdomen. But as we continue to examine the anatomy of the sleeve, this is the stent being placed and deployed. You can see the abrupt turn at the incisura. And when the stent is completely deployed, you see that not only is it quite tight there, but there's almost a fold, an abrupt torsion there, which is causing a functional outlet obstruction, which contributed to the leak in this patient. This is another example of a hyperacute perforation, of a perforation during bougie placement at the time of attempted sleeve gastrectomy. The anesthesiologist was having difficulty passing the bougie, and I unscrubbed and went to the top of the patient, performed an endoscopy. There was a less than 1 centimeter acute laceration at the end of a relatively tortuous distal esophagus. There's a clear cap on the scope, and an over-the-scope clip is ready to be deployed. The tissue is then sucked up into the cap, and this over-the-scope clip is deployed for that fresh and pliable tissue to come back together. On top of this, I did deploy a stent as well. We aborted the sleeve this day, but the patient was brought back 6 weeks later and underwent successful sleeve gastrectomy. So how about outcomes? This is a series that was published in SWORD from our experience in Cleveland, looking at mainly bariatric surgery complications, including leaks and stenoses. More than half required more than one stent, and more than 1/3 required more than one stent per procedure. And in our group, we prefer to use partially covered stents. Up to 90% of those patients underwent partially covered SIMs. Overall stent-related complications were quite low, including very few migrations. There were some intolerance requiring early stent removal. But if we look at the overall primary endpoint of resolution of leak, for leak after sleeve as an acute intervention, 81%. After gastric bypass, 100% in our series. But for the more chronic conditions like sleeve stenosis and fistula, less successful. Overall, 77% of our patients had improvement, highest among the leak indications, and 2/3 had oral intake within 24 hours. However, 30% of these patients eventually required surgical intervention at some point. So in a different series from Mayo Clinic, looking at more chronic leaks, up to 1 year out, a mean 386 days from initial operation to transfer, their overall success rate was quite low, less than 20%, and they had a high stent migration rate of 47%. But their conclusion was that esophageal stents, though maybe not successful in chronic situations, may temporize, suppress sepsis, and improve overall nutrition. And in the International Sleeve Gastrectomy Expert Panel Consensus Statement, leaks were categorized based on time from initial operation, acute, early, late, and chronic. And it appears for those leaks that are in that acute, early, and late situation, up to 12 weeks, esophageal stents may be indicated. But what do we do for these more chronic situations? A newer option that we have now is endoscopic internal drainage. These are biliary stents that are deployed through a pusher system, which are standard in ERCP, allowing for internal drainage of an abscess cavity. These traverse the defect, and instead of bypassing the leak like an esophageal stent, these allow for internal drainage. These are some endoscopic examples of a leak after sleeve gastrectomy in a chronic situation with the drain still in place. The defect is probably less than 1 centimeter here. We do a diagnostic upper endoscopy, a quick contrast injection, and a jag wire into that defect. And over this floppy jag wire, these double pigtail stents are deployed with 1 loop in the abscess cavity and 1 loop in the lumen. This is 1 in place. And then often when the defect is bigger, we'll place a second one as well. These are typically 7 to 10 French catheters, 5 centimeters in length. And the data on this is quite compelling. This is a group that looked at nearly 70 patients with leak after sleeve gastrectomy. 1 to 3 stents in place, changed every 4 to 6 weeks. Average time to therapy was 50 days with a failure rate of only 8%. 3 endoscopic interventions per treatment. And in general, these are much better tolerated than esophageal stents as well. So other considerations include not just leak, but narrowing and stenosis. And this is critically important for all operations, but especially sleeve gastrectomy. There are some certain principles that we understand better, which has decreased our leak rate. But we also need to consider this when we perform our endoluminal revisions for complications. This is an example of a patient who had a sleeve gastrectomy and doesn't have a leak, and the contrast goes all the way through, but you can see that there's spiraling of the sleeve. This patient has a functional outlet obstruction and reflux, but no acute sepsis, and may require a different sort of intervention. We get a better understanding of this in terms of making sure that the lumen is patent by using some sort of reinforcement prior to performing our sleeve. And in situations where that may not happen, or we encroach upon the lumen, there can be significant stenosis or reflux. This fluoroscopy shows a mid-body narrowing. You can see a lot of clips placed along the neo-greater curvature of the sleeve. This is the endoluminal image, which shows stenosis. These patients can respond to pneumatic balloon dilation. This is an example of an achalasia type balloon. This happens to be a 30 millimeter balloon done endoscopically and fluoroscopically. Under endoscopic vision, you can see the area of white here, which shows compression of the balloon across that stenosis. And under fluoroscopic vision, you can see resolution of the waist and improvement of that stenosis. Typically, you'll see even small mucosal tears like this with successful alleviation of that stenosis. For the sake of time, I'm going to skip over this video, but I do want to make a point that many surgeons do not perform endoscopy, and one of the real challenges for bariatric endoscopy is getting metabolic surgeons the skills to perform successfully these procedures. Both ASMBS and SAGES have a web-based video curriculum, which is paired with a multiple choice online exam and a hands-on technical evaluation that allows for certification in bariatric endoscopy. It's called Be Safe Bariatric Endoscopy Skill Acquisition Fundamentals Exam. This is the website if you have interest in looking at this. Please visit, and if you have any questions, feel free to reach out to me as well. So in conclusion, endoscopic access seems ideal for complications. It avoids the operative field and overall has a relatively low complication rate. New technologies are evolving rapidly, and as surgeons, we need to be a part of this. We need to take active roles in learning and progressing these techniques and technologies. And with that, I thank you for your attention and the opportunity to share with you today.
All right. So thank you, Mohit, and thank you, Matthew. And I think we're back on stage. So, okay, we have our panel here. So first of all, any question from our panel on this topic?
So Matthew, if I may ask, when you use this big Ovasco clips, firstly, because they bite quite deep, do you, because once the fistula is rather chronic, do you have to burn the track? Do you have any tricks? Do you actually do like sort of an ESD around the track to clip it? Or what's your trick to get these Ovascos to really work?
Yeah, that's a good point. So first of all, they come in not only different sizes, but different configurations of the tines. So for the more fibrotic tissue, there's a sharper point, which will elevate the tissue more. The problem with those devices is twofold. One, it doesn't address the abscess on the other side. So that has to be drained, whether that's percutaneous or there's an existing drain. So that has to be done first. The more chronic fistulas, if you're going to close them primarily, you want to make sure that the rest of the tract will collapse on itself. If you just close the luminal side, you're likely to have an abscess reform there. They work best in the kind of very acute situations where the tissue is soft and not so friable. If you're going to do a chronic closure with the Ovasco clip, I would agree that using an APC catheter, or if it's very large, an EMR. And then if you're going to do that, you may really consider whether you want to close it or you want to do an internal drainage. And that may be better served with a biliary stent or even a septotomy.
Okay, great, thank you.
Okay, and Mohit?
Got a question
Yes,
for you.
yes.
I do ESG as well. I kind of did about 15, 20, and then it dribbled off a little bit. Certainly, you're doing good work in India to really spreading it and increasing the population of bariatric operation, because otherwise this patient might not want any surgery. Just want to ask you, do you have a protocol on surveillances in terms of the stomach dilatation? Because a lot of the time I did look at it, some of the and ESG that I did, the suture do come loose afterwards, and maybe about 6 months or so. And then you notice the patient will regain some weight, and then would you go back? When would you go back in, or when would you offer them surgery?
Yes, so yes, we usually would not recommend any endoscopic surveillance. That's what I feel, because endoscopic surveillance can in itself cause some breakage of some sutures if that's done too early, before 2 months. After 6 months, yes, one can go in for an endoscopic surveillance, but I think it will not serve that much amount of purpose. What I would recommend is that we do a X-ray or a CT gastrographin study just on discharge and calculate the volume of the stomach pouch we created. And then this CT volumetry can be repeated, say after a period of 6 months, not before that, because that's the time when really we see that these patients start to show a high rate of weight regain. So that's one part of surveillance, a CT volumetry. After 6 months also, I am not doing endoscopies. I have not heard of other surgeons doing an endoscopic surveillance for ESGs, but if we have a significant weight regain, say if patients, they gain more than 50% of their lost weight over a period of time, then what we basically do is that we go in with a scope and take sutures again and try and reduce that pouch further. So one such trial of resuturing by endoscopy is given to this patient, and then we wait for some time. Almost 50% of these patients would come back again with weight regain, and then they can be converted into a suitable bariatric procedure.
Okay. And Mohit, may I ask you, apart from ESG, you also perform balloon, right? So what's the percentage or how of balloon as compared to ESG, and how you select each procedure?
So, you know, balloons have almost become, if I would say my bariatric endoscopic work, balloons are just 10 to 15% now, because balloons are much less tolerated by the patients than the endoscopic sleeve. Once that is an option available now in India, and the sutures and the device is freely available, balloons are less to be used. Most of these balloons would be adjustable balloons, which we use, but primarily if we give patients both the options, the only patients who choose to have a balloon would be because of the cost constraints, because balloon is a little cheaper as compared to the endoscopic sleeve. Rest, I think 80 to 85% choose endoscopic sleeve because first, it has more durable weight loss. Second, it is much better tolerated in the initial period rather than the balloon, which is, you know, causes a lot of nausea, vomiting, and severe epigastric pain.
Okay. So before we finish, we will have a poll on the practice of this primary bariatric procedure. And can we put it up? Yes. So we would like to know in the audience, how many of them are actually performing primary endoscopic bariatric therapy in your practice. So you can choose your center, you never do endoscopic procedure, or you provide intragastric balloon therapy, or you also, apart from balloon, you also provide ESG. So please, we can vote and see how this practice.
While we're voting, I want to echo Matthew's comment. I think we all ask our fellow to obtain endoscopic skill, because you can't call yourself a HPB surgeon nowadays unless you kind of do ERCP or EOS. So, and Ifso guideline recommending endoscopy beforehand. So it's much better to be able to diagnose reflux before surgery and treat complication afterwards. And I think it's a skill that must have, I think.
Okay, so we can see that although about more than half of people do not have endoscopic therapy, but still about 43%, it's not bad that your practice had endoscopic therapy. So I think this is a good start in Asia, that we should promote the use of endoscopy, especially in primary bariatric procedure. So it's interesting. So we have a question from the floor asking about, is there any study on the hormonal effect of ESG? So Mohit, have you studied or have you heard about the people doing this kind of hormonal study after ESG?
Yes, so I think the only one study I could remember is published by Lopez Nava, and that study is from Spain. I think he compared laparoscopic sleeve versus the endoscopic sleeve at baseline and at 6 months. I would just come to the conclusion of that study. So in nutshell, what they found was that endoscopic sleeve does not show that reduction in ghrelin levels and raise in GLP-1 like we see with the sleeve gastrectomies at 6 months. But definitely the insulin secretory pattern was better in patients with endoscopic sleeve, and the leptin levels reduced in patients with endoscopic sleeve. So at this point of time, I would refrain from calling endoscopic sleeve as a metabolic procedure in terms of diabetes resolution, because I think we need more data, because the data which we have for sleeve gastrectomy, which clearly proves that we have a GLP-1 surge and a radical drop in ghrelin level, we are not seeing that with endoscopic sleeve. But it is very heartening to see that we have reduction in leptin levels, and we have a very good insulin secretory pattern suggesting that the insulin resistance decreases after this procedure, but still to call it more like a metabolic procedure at this stage.
I think most this effect is related to the weight loss. The study showing the change on gastric emptying after the ESG, that may be one of the reasons, the slow gastric emptying. So we have one question.
Yeah, that's the reason.
Yeah, we have one last question for Matthew. That the patient will still repairing the esophagus laceration. So how do you know there is a perforation of esophagus, or is the patient behave different during surgery?
Well, this is kind of a surgeon's diligence. Hopefully you have the same team passing the bougie, and I don't know how the rest of the surgeons do it, but I often have the anesthesiologist do it. And when it's passed 2 or 3 times and you don't see the tip of it, you get worried that it's either coiled in the esophagus or it's gone somewhere else. So after doing that several times, I said, just stop. I unscrubbed, and my heart dropped when I saw that there was a laceration in the distal esophagus. But at least we identified it, did not proceed with the sleeve, and we repaired it endoscopically. But I think that's another great lesson, that you always have to have the highest suspicion that if something isn't working the way that you think it should, you need to investigate more. Yeah, I think that's a good lesson that surgeons should also learn the endoscopy skill, because you may need it anytime. You never know. You never know. Yeah. Okay, thank you. I think the section is almost end. Thank you everyone here to listen and also to present, and hope you enjoy the rest of the day. Thank you very much. Bye-bye.
Thank you. Thank you, everybody. Thank you. Have a great day. Thank you.
Good evening to you all across the Asia Pacific. I'm Maria Teague, Thoracic Professional Education Manager here at the Johnson & Johnson Institute. Ethicon is the proud platinum sponsor of the Ifso Asia Pacific 2020 Virtual Congress. And I would like to welcome you all to this Ethicon Satellite Symposium focusing on the new normal for the bariatric and metabolic patient. Faculty members for this fireside chat are hardly needing any introduction. Dr. Kelvin Higa is the Program Director of the Minimally Invasive Bariatric Surgery, Fresno Heart and Surgical Hospital in Fresno, California. He's the past President of the ASABS and past President of IFSO. Dr. Ahmed Ali is the Director of the Darabin Weight Loss Surgery in Melbourne, here in Australia. He's also the Head of Upper GI Surgery at the Austin Hospital and the past President of IFSO. Here are just some details in terms of the flow of this fireside chat. The faculty members will first discuss the changes that they made to their bariatric and metabolic care plan in response to the COVID-19 pandemic. We would then learn on the impact and outcome of these changes to the patient and to their multidisciplinary team. Dr. Higa and Dr. Ali will then reflect on where they see this new model of care fit into their clinics in the long term. At the end of the faculty discussions, we will answer your questions. You will see that there is a Q&A button on your screen. As you have questions, please submit them. We really want to make this interactive. We look forward to all your questions and we'll answer them at the end of the symposium. So without much further ado, I'd like to start asking you, Dr. Higa, and I'll call you Kevin. Going back in time, back in March, when we all had the COVID pandemic declared and restrictions were made and we were all asked to stay at home and bunker down. How did the pandemic redesign the way that you run your clinic in your private and public hospitals? How did you change it? How did you tackle these changes?
Yeah, who wants to go first? Ahmed, you want to start off or?
No, Kelvin, of course, I have to defer to the past president of IFSO, of course. No, take it away.
Well, you know, it's who'd have thought this is such an unprecedented problem that we had, and way back in the beginning, I mean, even in the beginning of the year, we were wondering not what was going to happen so much, but to what depth and what our hospitals and our government was going to respond. And I think we've learned quite a bit about all of these things. For our own practice, and our practice is in the United States is a private practice, but we also service what you call public patients, Medicare, Medi-Cal, things like that. We were at the beginning of the year looking toward a banner year. We're looking to grow about 20% this year, and with the pandemic, we had to shut down for 2 months, waiting for the possible onslaught of a lot of sick patients, which actually never came in California, not until much later. We had a shortage of PPEs. We had a lot of anxiety, mostly amongst the hospital staff, and less about the patients. And for some reason, our patients were more anxious to get going because many times we still had that 6-month mandatory weight management imposed by insurance companies, and they've already been standing down for 6 to 9 months. I mean, I don't know if you have the same regulations, but I mean, this really brings forth some of the issues we have in taking care of our patients, still having to do these unnecessary things that just slow down their care.
Yeah, absolutely, Colin. I think I echo your thoughts in the beginning. I think the best word to sum it up was confusion. You know, there was a lot of uncertainty at the beginning. We had heard about this COVID. We weren't quite sure what it really meant. What was the real implication of this? You know, on one hand, you had some people saying this was going to be the worst thing that had ever hit, and on the other hand, you had people perhaps suggesting, look, it's just a virus that's going to go away pretty quickly. And so as individuals, we didn't really know how to respond. And of course, then we were looking to leadership to try to direct that. I think in Australia, we were a little bit fortunate because it came to us later than the rest of the world. So we started to see the effects in Europe and particularly in Italy. We saw the signs. and in the UK, all of that big wave with massive numbers and high mortality, that all happened as Australia only started to accumulate cases that you could count on your hands. So we had forewarning, and we started to understand this was very serious, and it was going to mean that we were going to have to make some changes. But there was still confusion. What changes were necessary? How long would they last for? And I think as health practitioners, this meant that even as we started to devise ways of managing, we weren't really quite sure how much to invest. Do you change your entire system, or do you just make little adaptations to sort of manage at the moment? It wasn't clear. And I have to say in Melbourne, and I think in most of Australia, the initial changes that occurred in healthcare happened in the public system. That was where the impetus began. And I think it began there because that was where the concentration of infectious diseases specialists were. And they really were the leaders in this. They were the ones that saw ahead and said, no, this is very serious. We actually need to make contingency. And they did it ahead of government and bureaucratic recommendation or imposition. They were actually driving the agenda. That actually was useful for those of us that worked in a public hospital, because we were able to transfer that into our private and adapt it slowly. We had some direction. And it really took several months before we started getting direction from the government externally as to how to manage these things. But you're right, at the beginning, there was a lot of red tape. How do you change this? How do you move that? And I think as people realized the scale of the change that was required, a lot of that red tape got cut away. And I think that's one of the benefits, if you like, that's happened in the course of the pandemic.
Yeah, so I mean, did you find that a lot of your patients were more fearful of the disease, of the COVID, or they're more fearful of not being able to access metabolic surgery, bariatric surgery?
I think in the beginning, it's probably as you described, the patients were worried they were going to get cancelled. You know, our patients have invested a lot to get to that point of being on an operating list. And because there was so much uncertainty about COVID, the only thing they knew that was at risk was, am I still going to get my operation? If I don't get my operation, what does that mean? And when will it be? And how long? And that was a challenge as a health practitioner. I don't know if you found the same, Colin. It was a real challenge managing that anxiety. That's what all the phone calls started to be. And we didn't have the answers. Yeah. We didn't know how long. And
well,
we could start developing systems to manage that. So, you know, in our private practice, we established a database in order to maintain a waiting list so that patients that were cancelled could be kept in order, and we could reassure them that they weren't going to get lost, that we were going to be able to track them, that when we know more about how surgery will recommence, you know, because we got shut down, like as you're saying, when we knew when that was, we could reassure them that we had a robust system in place to get them into theatre, to get their treatment done. The other aspect was reassuring them that while we are not operating, we are still caring for them. To be honest, we didn't quite know how we were going to do that at the start. We had to develop that. So I don't know, did you find that a challenge, Kelvin, managing the patients that were?
You know, absolutely, from many different aspects, because one, we weren't allowed to see our patients in the office anymore because we were shut down, and therefore we, you know, we fortunately our insurers and Medicare allowed us to do telemedicine and get reimbursed for it, and that's been a big problem because we were trying to employ telemedicine 5 years ago, but because it wasn't a covered, you couldn't get paid for it. It was impossible. And now we've discovered all the benefits of telemedicine and how reaching out and all that sort of thing, which we can talk about later. But all of our referrals are specialists for the same issue. So we can't send people out for endoscopies, pre-op, or manometries. All of these things that we ordinarily do were shut down as well. And the patients themselves, when we're looking at a lot of them now losing their jobs, losing their insurance, losing their coverage, Can you imagine? You've already expended a lot of resource and time into getting this surgery. You lose your job, you lose your insurance, you don't have access. You may never again have access to obtain the surgery, all because of the bureaucracy that preceded this. And I think this brings forth the bias against you know, the procedures themselves and the misconceptions about this. And I think if anything that should come out of this is the idea of prevention for all those patients that have already had surgery. I mean, have you seen any evidence that, you know, after surgery, after their diabetes and the weight's down, patients should have less of a risk of mortality if they do get COVID? Do you agree?
Well, so I agree based on the literature. I can't say that I have personal experience with it because fortunately in Australia, we didn't have many deaths and our deaths tended to occur in the elderly. We had most of our issues occurred in the nursing home population.
Yeah.
And I think that was because we had forewarning. You know, we saw what had happened overseas. We were able to quickly adjust and create appropriate infection control measures and to shut things down. Yes, that made other aspects of delivering care difficult, but it did deal with the numbers quickly, and fortunately we had little death. So, you know, that's an interesting point that you make. I know it's been discussed a lot certainly in Europe, well, I defer to you for the States, but there's been a fair bit of discussion about obesity being a risk factor for COVID death. This really hasn't gained any traction in Australia, and I think it's because there's been very low mortality. We can try and raise that conversation. We know it to be true, but it's something that is not in the forefront of our health policy makers or the consideration of other physicians, for example, because it simply hasn't been a major factor in Australia. So is this been a real discussion point in the States?
You know, not so much, because you know, there's so many other things going on right now. But I think that it's subtly undertone all the discussions. How do we decrease the risk going forward? While we're waiting for the vaccine, which appears to be on the horizon, how do we mitigate future problems? And I think that the medical community as a whole is becoming more acceptive of what we have to offer. But you know, this is really very regional in its acceptance, and it really shouldn't be. So I've been as I look at the deaths, you're right. Australia, New Zealand, I mean, really has taken the lead. Do you think because of the way your health system is unique in a way, you're better set up to adapt to this crisis than say us in the United States?
I think look, it might be part of the health system. I think it's part of the system of government, and I think for everybody that's tuning into the session, it is going to be different in every country. It depends on how you're set up and what the response is. I think in Australia we have quite a strong, I suppose, central government response. There was clear directive from the federal government. The states varied somewhat, but they had to take direction from the federal government. It was pretty strong. I think our biggest advantage was forewarning. I think that allowed the government to take the interventions. But I guess, Maria, I'd like to try maybe bring it back to, practical steps for the surgeon, early on. So if I think back to the start of the pandemic for us, the confusion was a major challenge. Once we had clarity on the fact that, yes, we are going to get shut down, then we were able to start taking concrete steps and say, well, okay, well, what does that look like? What does that mean? And certainly in the first wave, there was a lot of adjustment to make. There was a lot of redesign of service delivery. So one aspect was dealing with the anxiety of all the patients. We've discussed that. The other aspect was, well, okay, well, now how do we actually manage the patients going forward? And it wasn't long, you know, during that shutdown or the cancellation of surgery, patients started ringing us saying, I'm gaining weight because I'm at home, I'm in lockdown, and the fridge is there, and I'm, you know, I'm going nuts, and the family's killing me. And it wasn't just our pre-op patients, it was our post-op patients. I mean, so I was doing really, really well, and now I've plateaued, and now I've put on 2 kilos, and I'm struggling. What do I do? What do I do? So immediately there was a challenge to the way we deliver bariatric care as a whole. Now, in our own practice, in the private practice, our dietitians and psychologists got together and started creating if you like, a COVID at home package sort of idea of support for these patients. And they were forced to develop new materials, new educational, new ways of trying to support these patients, different to the traditional face-to-face consultations that used to occur. And so again, this has been this innovation and redesign that's needed to happen to help support patients through COVID. So I'm using that as one example. Perhaps Maria, I don't know, did you come across other examples from some of the other surgeons you've spoken with? Or?
Yeah, and I'm curious to see to what extent you had to change or what you changed and what you think has been really valuable both for your team and especially for the patient in the long term, because you've probably made some quite good discoveries on how to make things work, maybe more efficiently, allowing the patient to access their care from anywhere. They don't have to come in and see you at a particular time, and there may be some savings in time for your front staff in terms of rescheduling or, you know, the management of appointments and the like. So where do you see the positive and I guess some negative impacts for the patient and for your staff?
You know, for us, I'll tell you, the whole telehealth situation has really been a very positive experience. I can't say we're as efficient as we were when we brought patients into the office and made them wait for a couple hours and then, you know, shushed them on the way. But from the patient standpoint, now it's we access them while they're at work. They answer their phone, we get them on video, they go into a closet, we have the discussion, we talk to them, and then they go back to work. And it really is quite you know, more convenient for everybody. We're certainly burning a lot less fossil fuels and having a lot less patients just waiting around for us. As you know, I don't know. Well, I mean, I know for I'm always late, 1 or 2 hours in the office in the clinic, and you're probably right on time. You know, knowing Australians, you know, that's the way it is. And we've been able to take our dietary, our follow-up, all of our visits can be infinite in number. So in the past, we would be landlocked by the size of our conference room and the availability at certain times. And now we can have one patient, we can have 20, 200, all on a Zoom call, accessing the dietitian, the psychologist, and the follow-up, you know, as we go. So, and then our staff, for them, it's been nice as well because they have lives and they can start working the patients at their leisure, off hours, weekends, and for us as well, we can access patients and at any time. So it's really been, connectivity has been really a great bonus. Hamid, did telehealth, did you embrace telehealth as much as we did, or is it it's always been that way?
No, a bit like as you were saying, there was no funding for telehealth as such. So if you conducted a telehealth consultation, technically speaking, you couldn't actually be reimbursed for that. There was no item number for that. We use an item number system. So that was one of the things that COVID did accelerate very quickly. You know, almost overnight, the government approved a whole lot of item numbers for telehealth, not just in medical care, but also ultimately for dietetics and for psychology. So because they recognise they had to do that, you know, for healthcare as a whole in this climate, you can't very well say to people you must stay at home except for emergency care, and tell people you must work from home unless absolutely necessary or part of a central service, and then not support it by some way of actually being able to conduct that. So again, this, emergency also brings, or catastrophe can also bring opportunity, can bring development, can bring acceleration of technology and its use and innovative ways. And I think this has done that. So yes, one thing that was critical was the funding of the telehealth consultations. The next thing though was to try to work out how was the best way to use it. And to be honest, I'm not sure we've completely sorted that out. We just, we got thrown in and we just had to start doing it. What I would say is, personally, just myself, just consulting, sometimes I find it very beneficial and more efficient and quick. Other times I find it very frustrating. And it's due clearly to the type of patient you're seeing, because it doesn't always suit all patients, and the nature of the consultation. And what I'm finding hard, I don't know if you've found a solution, Kelvin, please email it to me or put it up here. How do you pick it? How do you know in advance which one's going to work and which one's not going to work? Some of them you can do, but I haven't seen an absolutely clear pattern. And I would also say the other mistake we made, I think, is we didn't have a single platform. So our consulting sessions started to become hybrid. I'd have 2 or 3 face-to-face patients, I'd have 5 or 6 telephone calls, and then I'd have, 7 or 8 or 6 Zoom calls. That's not a good way to run telehealth. When you're jumping from one platform to another, it's confusing. And one of the challenges, I think, of something, for example, like a Zoom platform is, when you're normally consulting, face-to-face, it's a waiting room. You've got patients in a waiting room. They're either there or they're not. And if they're not there, well, then they're not there and you move on to the next patient. The problem with a Zoom waiting room or a Zoom appointment is, well, are they not there because we mucked up the link? Or are they not there because they're having technological advances? And should I go on to the next patient or do I wait? Did they even get the message? Well, they've replied. So there's all the technical. I think the commonest phrases of the COVID period have been, is this working? Can you hear me? Can I see you? I think that phrase, those phrases have been said more than any other phrase during
exactly. I think we had the same problem with, it's like setting us up with Maria. It's, let me close out the video and I'll just call you on the phone.
Yeah, exactly. So there's that, and the same with the telephone. You pick up, you ring them, they don't answer, then you start, okay, I'll move to the next patient, then they ring back, and then you've got to, juggle. So for anyone that hasn't explored telehealth yet, these are some of the issues I think that you've got to think about. And if, in an ideal world, you would set this up in advance. And what I would suggest is have one platform, stick to it, and get a slick system that patients can manage. And have someone other than you doing the consulting, managing the patients that are having trouble connecting. Otherwise, it turns your consulting session into being very, very inefficient and difficult. So, these are the stumbling blocks when you haven't had a chance to plan. But yeah. I certainly see a role for it going forward. I think there, as you mentioned, for patients, they love the convenience that they don't have to take a day off work or they don't have to, so on. So I think, yes, once we've worked out what consultations work well and what we can use them for, then there's definitely a place going forward, and that's been a boon. And it will be good, I think, for all of us to share our experience and ideas on that so that we get better at it. I think there's a real positive. I'm really interested, I don't know if you've done this, Kelvin, I'm really interested in the use of technology. So it's not just the telehealth, but the social media platforms. I mentioned earlier, we talked about patients struggling at home gaining weight and wanting to come in and see the dietitians more than ever. I mean, usually we have trouble getting them to come back and see the dietitian. Now that they're stuck at home, they don't have any other options. Now they're all booking, the dietitians are overbooked, they can't do it. So we had to come up with new ways. So we developed social media online programs that they could access that was through a private chat group on, from our clinic. And the girls were terrific. They developed the materials for this We jokingly called it fattening the curve, you know, because everybody talks about flattening the curve.
Sure, sure.
Unfortunately, they're all unfortunately fattening the curve. So we developed that program, and we will continue to use that because it was a really good way, as you say, connectivity, engagement, delivering it to more people at one time, offering support in a new way. I think the pandemic's helped us crystallize ways of doing that that we can take forward. But I want to extend that into patient-reported outcomes and data collection. You know, there must be, and I'm sure some people are already doing it, but there must be ways that we can reduce our clinical review burden by using some of these technological automated tools, so that patients essentially almost do their own follow-up, and we are able to review those results. And you can have, you know, perhaps have flag systems. So, you know, this one's having trouble with X, right? That's one that we need to get back into the rooms. You know,
yeah, absolutely. I mean, today, you know, everything's connected. You get a scale, a sphygmomanometer. You know, you can measure body composition, hydration, blood sugar. It can all be fed in automatically and surveyed and make it much more efficient and much better off. You know, I think we're right on the verge of all of these technologies coming together for the betterment of our patients, because this bricks and mortar, seeing every patient and recording them and having them upload their data with you know, more than 90% fall off at 5 years is not cutting it. And we have to accept the fact that it isn't going to be. It's just we looked at you know, putting in all of the data that MBSA puts in, and the FTEs that it requires to put in. You know, with doing over 1,200 cases a year, we anticipated that by the year, I think 2024, the salaries of just the data abstractors to put in the data was going to be over $1 million a year just for their salaries, and so it's not sustainable. And I've been surprised. I don't know about you. I was worried that with you know, talking into a camera like this, you kind of miss that the person, you know, shaking hands, that sort of thing, the connection. I found it to be the opposite. You know, when patients come to the office, they're a bit standoffish. They're intimidated. They are quiet, and when I access them at home, boy, it's like the whole family's chiming in. You don't know who's in the background. You ask them about a diet, and the husband says, "Oh no, you're tell them the truth. Tell them, you know, all these things going on." And I remember one patient who was seeing for weight regain, and on the phone, just on the video, you could see it looked like she hadn't had a sleep in like 2 weeks. There was crying in the background, dogs barking, and I said, "What's going on?" "Well, you know, I have to homeschool my 3 kids, blah blah blah, on and on and on." And I said, "Well, it's quite obvious. You don't need an operation right now. You need some rest. You need some pharmaceuticals here. We're not going to do surgery on you." Had she come to the office, you know, presenting herself real well, I would have taken a different tact.
Yeah. Well, similarly, our dietitians have found it very useful because they've actually been able to virtually visit the patient's pantry.
Yeah. Absolutely.
and done clinics with them, reviewing what's in their pantry and how they go about preparing meals and stuff like that, which you could never have done, you know.
So you know, so in my point of view is because when I look at the future of healthcare, and you know, it's in the United States, I don't know what it's like in Australia, but you know, we're looking at, you know, close to 20-30% of our GDP is devoted for healthcare itself. We know that's not sustainable, and it's too expensive, and we don't really concentrate on preventative medicine, just, you know, end of life care and interventions, that sort of thing. Has to be a change, and the change doesn't come without pain, right? The dinosaurs didn't get wiped out till the asteroid hit the planet, and in some ways, the COVID experience is forcing us to make changes at a great cost, a great number of lives, but it's forcing us to make some changes that we needed to make in a long time. I mean, at the end of the day, if we can get this vaccine and put an end to this, don't you think that we're going to be better off?
Oh, I think so. Yeah, I think as we've been discussing, there's a lot of tools we've developed out of necessity, which we've now seen some advantage in that we continue to carry forward. I think the Holy Grail is working out exactly how to take it forward in the most effective manner, because there's certainly aspects of it that I'll be honest, I find very frustrating. And sometimes I find myself on days saying, I just want this to be over and so we can go back and doing things the way we normally do them. Because there are some things, and it's, it's partly the bureaucracy mentioned right at the start, that we have to now follow all these COVID protocols. And yes, they're important and we need to do them, but boy, it gets tiring. What used to take 10 seconds, booking a procedure or organizing something, now it takes half a day, and patients have to get swabbed 2 days before and they've got to isolate, and it's just, there's a lot of extra labor, so it's getting everybody fatigued. But there are certainly advantages in things like we've talked about telehealth, in developing new ways of patient follow-up. I guess one area I wanted to ask about, just something we've all been discussing, and we've discussed the medico-legal aspect of it within the public hospital, we've discussed it outside, and just from a practical point of view, was the process of consent. I mean, telehealth creates a little bit of a challenge, I feel, when it comes to informed consent. And the methodology that we adopted during lockdown was that we would conduct their initial appointments by telehealth. But when it came to consent, we did a face-to-face. We had them come in. But of course, our need to consent was only when we started to reoperate. So during the 3 months of lockdown or 2 months of lockdown, we did mostly telehealth consulting. Patients went onto a waiting list. When it came time to start surgery again, then we asked them to come in for a 15-minute consultation for consent and then proceed. And I personally have found it difficult to consent patients in a telehealth manner. Now, again, I suspect that's going to be a little bit based on your local medico-legal environment and the way your legal teams tend to operate. Mm-hmm. But we felt that there was, a medico-legal risk in trying to do consent by telehealth. But also just genuine concern that it's much harder for patients to understand when it's virtual rather than being there face-to-face, perhaps even, drawing diagrams or doing things that are specific for that person rather than a generalized sort of discussion. Have you found the same issue, or do you guys manage it a different way?
No, I mean, our consent is more of a process. It begins with the intake. We used to have patients actually take a test after they've seen a video, going over many different things, so we know that it's always consistent. But we felt that, even having a test is somewhat demeaning, and it's kind of a barrier to the patient. So we still have the video. We still have a 5 or 6 page legal document that they can do over the internet, that sort of thing. But the consent really is a continuum. It starts with the consultation, then every touch point after that, and then the final thing is a preoperative visit. Now, the preoperative visit is often done with the residents or the fellows, going over different things. And again, that's another one of the bonuses with the telehealth system, because we had already set it up where I had taken away all the surgeons' offices, because we're the surgeons, so we all have the nice offices with the windows and the outside of the building, and all the workers are the inside in a cramped quarter with no windows and no windows and no doors, and and we're only in the office like 1/10 of the time. So I said, this is ridiculous, and so I put all of us into one big room with some cubicles so we could interact with each other much better. And we gave the outside offices to the worker bees of the office. But now that our residents and fellows are sitting next to it, I can overhear 3 or 4 of them talking to patients as I'm talking on on the telly, and that's allowed me to kind of screen what they're telling patients. They can hear what I'm telling patients as well, and so when they're going through the consent and things, I can kind of peruse everything that's going on. So I think it's actually been a lot better in that way.
That's Big Brother, isn't it, Kelvin? You're just looking over the top and spy. Is that spyware? Is that a new kind of technology?
No, it's called micromanaging 101. It's just.
I'm very sorry to say we've come to the end. I think it's been incredibly insightful to me. I take away you have experienced some real tough times and you had to be very agile in managing your patients that just had surgery, they were waiting for surgery, looking in the long-term perspective of how to follow up patients long-term. Develop some amazing new models for interacting between your multidisciplinary team and the patient. Some patients may fall through the crack, but others also open up more because you see their world and they can come and see you at the time convenient to them. So I guess we've found that bariatric surgery probably was very well suited for telehealth, but we need to all come to conclusion on what the secret sauce is. Like, well, what extent do we keep it, and to what extent do we go back to some of the normal? And I think if you wanted to just send off one last thought to the audience before we go into the Q&A, how do you think we can encourage patients to, or can we encourage the community to raise more awareness of obesity in relation to COVID risks, and also to make them feel more comfortable to go ahead with their surgery, because many actually fear and defer their surgery here in Asia Pacific?
Ahmed, you start.
So the first one, the obesity as a risk factor in COVID, the ongoing problem of obesity, I think as time passes, so right now we're starting to see a second wave. Over time, we will probably see a third wave. It'll be smaller again with less mortality. I think we're coming to the understanding that we're going to be living with the virus for some time to come and years to come. And as that realization descends, there will be focus turning again back to the kind of normal health discussions that we've always had. And obesity will still be here, and its comorbidities will still be here, and it'll still be creating the ill health and the threat that it does. But in addition, it'll also, now we'll just add to it, and being obese increases your risk related to COVID or other infective diseases. So I think it'll become absorbed into part of the discussion, and perhaps a further impetus to start addressing that, addressing obesity as an important health issue, which it already was before COVID. It still is during COVID, but everyone's distracted. And then as time goes on, we realize, no, we're going to be living with COVID, and now we need to still be addressing our obesity issue. I think that's how it's going to play out. I think as bariatric physicians or surgeons are involved in bariatric care, again, it's about it grabbing the attention. So when that focus does start to shift, it's an opportune time to again re-establish the campaigns for advocacy that we've always been doing. Reduce stigma, increase access to surgery in an equitable manner. Certainly in Australia, we've been working hard on trying to increase public bariatric surgery. And again, the obesity, the COVID situation adds some impetus for that advocacy. So incorporate it into your advocacy message. I think it's the dripping tap. It's not you're not going to get a sudden change of heart, simply because of COVID existing. Kelvin?
Well, yeah, I agree with everything. You've said. The other thing is COVID doesn't attack just the obese and the diabetics, but it's a racist bug as well. The death rate is much higher among African American and the Hispanic communities, and the disease burden is greater. But that's also where the metabolic syndrome lives too. So I think this is a call out to the bariatric surgeons and the bariatric community and all of healthcare to really concentrate on where the disease lives, and go after it, whatever disease that is. And it's a great disservice when certain aspects of our society don't have access to care. Maybe not so much in Australia, but United States, at least 10% of our population don't have any health benefits whatsoever. And I personally think that's abominable. I can't. It's hard for me to understand that and justify that in any way.
At heart, we're still physicians trying to care for those that need it most, not simply the financially viable.
Absolutely, absolutely. Well, Ken, after we wrap up, maybe I haven't enjoyed this talk so much. Ahmed, you want to stay on for a couple hours? I can talk to you for a long time.
Yeah, well, Kelvin, I'd love to actually. I could, we've still got a lovely, warm Melbourne day here, so I know things are getting a bit cooler where you are. So I can bring you out into the sunshine. We can continue the chat.
We hope to see you here and to meet in person very soon. Thank you so much. And we are now moving into the Q&A. So thank you very, very much for all that knowledge and sharing of knowledge.
Thanks, Marianne. Thanks, Kelvin. Lovely to see you. Great.
Take care. Bye-bye.
Bye.
Well, good morning, Kelvin, and good evening, Ahmed. It's extremely early for you, Kelvin. I'm so happy that you're up and awake with us, and same for you, Ahmed. We're trying to break records of having no sleep, I think, across the world. We got a question from the audience to you, and it was in relation to the virtual support groups, and I guess in regards to the community as well, the patients' community. Did you run your patient seminars and support groups also virtually? And what was the structure that you used for these?
Yeah, I think, Maria, our connection is a little bit slow again for some reason, but Ahmed, you can hear, you're look pretty clear, right? Yeah, excellent, excellent. But so I think the question is, what about support groups, and are we doing that virtually as well? And yeah, we are actually, and we're embracing it. And actually, patients have been doing that forever on their own through their Facebook chats and things like that. They've been supporting themselves even before we officially adopted this, because we have all these HIPAA, regulations and all. We were concerned about people infiltrating the group, and we don't know what they're saying and that sort of thing. We're still somewhat concerned with that, but we don't have the ability to monitor all of the chat rooms that have been going on, and there's some disinformation being spread. But this is a very convenient way for all of our patients to connect, better, rather than at a prescribed time. They can log in at off hours, see what's been said. They can't participate as well, but I think it levels a playing field so that in any group meeting, there's usually one or two people that sort of, unless you have a very good leader, they sort of monopolize the entire group, and now you can sort of flip them off, so to speak, electronically, so you can silence them. And we wish we had that during our first presidential debate, but nobody really anticipated. Well, I think they did anticipate it, but they weren't were going to do it. So what about you, Ahmed?
Yeah, Kelvin, we've actually run a closed Facebook group for our patients for quite some time. And many of our patients want to keep their surgery relatively anonymous, so they don't like posting on public Facebook groups and that sort of thing. But we have a closed group for our patients, so only we can add them, so we know we can verify that they're a patient of ours. Anything that they post is screened first by our clinic nurse. So it's reasonably well moderated. We've always found it a very useful tool for support for patients, but also as a means of follow-up. Sometimes you'll find patients that haven't been back for follow-up for a long time will suddenly post something on that group rather than call us. It's a very strange thing. But you know, that's the way of the world at the moment. So they will post, and that'll give the nurse an opportunity to re-engage with them. And I'd say that Facebook group became more important, even more so after the pandemic started. So it started to be used as a primary means of communication amongst patients, but also with the clinic.
Are you a big Facebook user?
Sorry?
Oh, I'm sorry, I didn't mean to interrupt. I just wonder if you were a big Facebook user, because a lot of us older surgeons are not.
Personally, not really. We do. I mean, we do it a little bit, but no, I'm not a big social media user. And but we've found this group to be a very good way, this closed group, and it became a very good tool during the pandemic as two-way communication. So patients were communicating with the clinic more often and more directly, and also we were able to communicate updates on what was happening with elective surgery. We were able to make little educational videos, for example, so they could access that at any time whenever it suited them. It wasn't necessarily a specific sort of webinar time. Our integrated health staff, you know, made educational pamphlets that were specific to concerns that patients were raising during the pandemic. So it became an even more useful platform. We could see how we weren't making the most of it before the pandemic, and now we see it has a lot more potential. So that was one of our major primary forms of support.
And do you think patients are going to be wanting you to continue with this sort of support going forward? Let's say we all go back to normal tomorrow. We won't. But do you think, have you heard them expressing the need to continue this new form of consultation?
I think they vote with their feet. I don't know that they actually need to say it. I think the simple fact that they are using it more and more, we are finding attendance greater. It has made us busier in terms of answering questions, you know, because they've got easier access. So I think regardless whether they express it or not, it's clear that they like using it.
Yeah, there are a few patients that they really want to see you in person, and they're the ones that really are more vocal about this. But for the most part, I agree. They don't. What they're saying is, and you can tell because of the no-show rate is way down, compliance is up. We know that it's better outreach. We know that we are able to follow up better this way than we could by making them take a half day off from work and drive in and that sort of thing. And an offshoot is that you know, we get a dozen or so calls every day just from people that we haven't heard from in 10 years asking a rather simple question. And in the past, we'd have no choice but to have them make an appointment 2 or 3 months later, and then it's not contemporary. So that we're able to now connect with them, actually document on the record and that we've had a consultation, and it's on their time. And I think it's all very good.
Did you find this too, Ahmed, that your compliance went up? Because that's a very, very big and important part of all of this.
We haven't formally measured it, so it's hard to say that. But I do think there has, as Kelvin's point about addressing things at the time, there's been more of that because it's been easier to schedule a telephone review than a formal face-to-face review, because it's easier for patients. Like Kelvin said, they don't have to take a day off work or you know, even if you just listen to the receptionists trying to book appointments, normally they say, well, I can offer you 4:45 on Tuesday, and they go, oh no, I have to pick up the kids at that time. What else have you got? And you can just see them spending quite a long time trying to find an appointment slot. But when it's offered as a telephone review, very often the patient says, yeah, well, I'll be picking up the kids, but I can take a call. Yeah, that's fine. And so it just becomes easier to schedule.
Fabulous. And I guess if we should talk about something that could potentially be negative, I guess that could be missing vital signs, or the patient that doesn't connect with you and the risk involved in that. What are your thoughts on how to address that and mitigate that risk?
I think, Maria, over time with our training, we get pretty good at being able to tell over the phone where the flags are. It's kind of one of the skills you develop as you become a surgical consultant. You know, you have to learn how to ask questions in a certain way. So you can pick up the flags and then you can bring that patient in specifically for face-to-face, or admit them to the hospital or whatever else if you need to. So we haven't seen an increase in risk. And our nurses are all trained to respond. You know, they know the key questions to be able to pick up the red flags. And we have very low thresholds to intervene. So even if that means just measuring a CRP or something like that. So all those systems, I think, are in place. They've just been enhanced because patients are more ready to make their consultations online. I think that's fine. Where the pandemic had an effect, I think, is in terms of patients initially not making contact, or certainly not wanting to come in for a face-to-face, or not wanting to come to hospital. And so there were delays in presentation, not so much in bariatrics in our experience, it was much more in cancer type and screening type things. But there was also an implication in bariatrics. So patients were delaying their consultation or putting up with a symptom that was reflective of a complication for longer before they presented initially. I think that's changed now.
Yeah, I think, you know, I agree. I think overexposure, our exposure is less. And a lot of it has to do just with our own time management. So, you know, in between cases and things, we can connect with patients after hours, weekends. You know, our office hours are virtual now and not tied to, you know, a 9 to 4 office time 5 days a week. And our overhead goes down, so we are able to concentrate all of our expenditures in different areas, not just staffing an office, bricks and mortar, but, you know, looking at more successful ways of reaching out and supporting our patients. As we all know, that follow-up is just a big problem, no matter what our organizations and what we ethically think we should be doing. I mean, forever it's been about lifelong follow-up, and so my whole career was, at least the lab half is trying to make myself obsolete so that I can walk away, but my patients are totally taken care of. And I think we need to rethink how we follow up on patients, because obviously just wishing for it to happen isn't cutting it. It's not getting done.
Yeah, I see a real role for remote assessment and self-reporting in improving the percentage of follow-up, because like you, Kelvin, we've found the same thing. You can try and do everything, feel like you're doing it well, and then you actually go and measure your follow-up and it's disappointing.
Yeah, you know, it's funny because almost every article on the subject begins with, we all know how important follow-up is, but I think our practices have shown how actually the opposite, how irrelevant the follow-up is, because the results are good, even if they don't follow up, even if our patients don't follow up. We'd like them to, but how much good are we doing them, seeing them year after year and they're doing fine? And it's really the patients that don't follow up that we're catching the vitamin deficiencies and things like that, which I think is an inefficient way of just screening randomly. So we need to think, you know, a different way about all of this, because it certainly isn't sustainable.
That's right, and I don't know if you've watched, there's just a documentary called The Social Dilemma. I don't know if you've seen that documentary, but it's about the rise of social media and the way the internet has moved, and some of the devices that have been developed, or not devices, but some of the techniques that have been developed that essentially are there to make people stay engaged with the screen. You know, so little tricks, little things like your mail inbox shows you how many unread emails you have, or, you know, you get an alert on something. So it sort of kind of compels you to open it. You sort of feel like you have to do something.
Yeah, I've always felt manipulated, you know,
Exactly.
for a long period of time.
But maybe it's time for us now to use some of those techniques to get our patients to respond. So, I mean, those, you know, there are experts there that have developed all of those techniques. We just need to shift them into self-reported follow-up. And at least that would be a useful engagement for a patient.
Absolutely, absolutely.
Lots of amazing ideas, and I think you highlighted halfway through our main part of our session, Arma, too, that it's so important that we keep sharing these experiences with each other. So thank you for the time and all the insights that you have shared with the community here in Asia Pacific. Let's keep sharing, and we are strong together. So thank you so much for the time, and good night, everyone.
Thank you. Good to see you guys.
Bye-bye.
Bye.